Votre attention, s'il vous plaît. Bonjour à toutes et à tous. Je pense que nous allons démarrer très très rapidement cette cérémonie d'ouverture dédiée au centenaire de l'Institut Pasteur de Dakar. Nous accueillons présentement le docteur Ibrahim Assi, ministre de la Santé et de l'Action sociale de l'État du Sénégal. Bonjour docteur. Je pense qu'on est fin prêt pour démarrer. Bonjour à toutes et à tous. Ce matin, mesdames et messieurs, nous célébrons l'excellence. Mais j'aimerais, si vous me le permettez, avant de souhaiter une chaleureuse bienvenue à nos honorables invités en leur rang et qualité distinguées, faire un petit cours d'histoire. Il y a exactement 128 ans, en 1896, une certaine Émilie Marchou, élève de Louis Pasteur, inventeur du vaccin contre la rage, montait à Saint-Louis dans le nord du Sénégal, un petit laboratoire de microbiologie. En 1913, ce laboratoire était transféré vers Dakar. En 1924, il devenait l'Institut Pasteur de Dakar. En 1937, dans l'intimité des laboratoires de cet institut, était créé le premier vaccin contre la fièvre jaune. Inutile de vous rappeler à quel point cette fièvre hémorragique virale aiguë constituait à l'époque un fléau planétaire. Et depuis lors, ce vaccin, une seule dose de ce vaccin suffit à conférer une protection à vie contre la maladie. Ce vaccin, reconnu par l'Organisation mondiale de la santé en 1966, balisera la voie, enfin, à une reconnaissance internationale de l'Institut Pasteur de Dakar en tant qu'institut africain de référence dans le domaine de la recherche scientifique. Aujourd'hui, mesdames et messieurs, l'Institut Pasteur de Dakar célèbre un siècle d'existence. 100 ans de présence, 100 ans d'existence, de travail acharné, de dur labeur, de collaboration avec des institutions et des partenaires, d'engagement dans la formation, le renforcement de capacités et la recherche scientifique. Mais 100 ans d'existence, c'est également une occasion saisie aujourd'hui par l'Institut Pasteur de Dakar de se projeter, de se tourner vers le futur, de réfléchir autour des actions concrètes de nature à assurer un avenir meilleur à la santé publique en Afrique. Et je pense que pour toutes ces raisons, je vais vous demander des applaudissements bien nourris pour l'Institut Pasteur de Dakar qui fête son centenaire ce matin. Je vous remercie. Je m'appelle Sarah Cissé, je suis journaliste professionnelle des médias et j'ai le plaisir ce matin d'animer cette cérémonie d'ouverture dédiée au centenaire de l'Institut Pasteur de Dakar. Alors je m'en vais sans plus tarder tout de suite souhaiter la bienvenue à nos invités, nos honorables invités en leur rang et qualité distinguées. Son Excellence, le président de la République, Bassirou Diomaye Diakhar Faye, représenté ici par le docteur Ibrahim Assi, ministre de la Santé et de l'Action sociale, professeur Peter Piot, président du Conseil scientifique de l'Institut Pasteur de Dakar et du Conseil stratégique du Pasteur Network, coprésident de la célébration du centenaire de l'Institut Pasteur de Dakar, professeur Awa Marie Kolsek, présidente du Forum Gallienne Africa, et ancienne ministre d'État auprès du président de la République du Sénégal, coprésidente de la célébration du centenaire de l'Institut Pasteur de Dakar, Dr Chikwe Yekweazu, directeur général adjoint pour les systèmes d'intelligence et de surveillance des urgences sanitaires à l'Organisation mondiale de la santé, Dr Amadou Alfassal, administrateur général de l'Institut Pasteur de Dakar, Mesdames et Messieurs les représentants de l'Organisation mondiale de la santé, Mesdames et Messieurs les représentants de l'Africa CDC, Mesdames et Messieurs les partenaires stratégiques de l'Institut Pasteur de Dakar, Excellences, Mesdames et Messieurs les ambassadeurs, Mesdames et Messieurs les recteurs d'université, Mesdames et Messieurs les professeurs d'université, Mesdames et Messieurs les membres du comité de direction de l'Institut Pasteur de Dakar, pasteuriennes et pasteuriens, chers invités, bienvenue à la cérémonie d'ouverture du centenaire de l'Institut Pasteur de Dakar. À présent, place au discours. La personnalité que nous allons accueillir tout de suite est un pur produit de l'Institut Pasteur de Dakar. Enseignant reconnu, membre de nombreux comités scientifiques, il préside le Pasteur Network depuis 2021, un réseau mondial regroupant 30 instituts. Distingué par plusieurs prix prestigieux, il est régulièrement consulté par des organisations internationales telles que l'Organisation mondiale de la santé pour son expertise. Virologue, expert en santé publique, il a joué un rôle crucial dans plusieurs pays africains lors des épidémies d'Ebola, de Zika, de COVID-19, ainsi que dans d'autres urgences sanitaires, dirigeant des missions sur le terrain. Depuis 2016, il est administrateur général de l'Institut Pasteur de Dakar. Merci d'accueillir sous vos applaudissements le docteur Amadou Alfassal.
Merci beaucoup. Monsieur le ministre de la Santé et de l'Action sociale, Dr Ibrahim Massi, Madame la ministre d'État, professeur Awa Maricol Seck, coprésidente du centenaire, Monsieur le professeur Peter Piot, coprésident du centenaire, distingués invités en vos rangs, titres, grades, chers collègues, Mesdames et Messieurs, c'est un immense honneur pour moi de prendre la parole aujourd'hui à l'occasion du centenaire de l'Institut Pasteur de Dakar. Ce moment est à la fois une célébration de notre histoire, une reconnaissance de nos contributions, la vitalité de nos partenariats et une promesse pour l'avenir. Nous voulons rendre hommage à notre passé glorieux, mais aussi préparer et bâtir un avenir radieux. C'est pourquoi nous avons choisi le thème « Autonomiser l'avenir », un centenaire d'excellence en santé publique. Monsieur le ministre de la Santé et de l'Action sociale, permettez-moi, avant d'aborder ces différents sujets, de vous remercier de votre présence, de votre engagement sans faille et de celui de vos équipes dans la préparation de ce centenaire. À travers vous, je tiens à exprimer ma gratitude au président de la République et à son gouvernement pour leur soutien indéfectible à l'Institut Pasteur de Dakar. Nous remercions également tous ses prédécesseurs, ainsi que les dirigeants d'hier et d'aujourd'hui, pour leur vision, leur engagement en faveur de la science et de la santé depuis la création de notre institut. L'État du Sénégal a investi dans nos infrastructures et facilité nos efforts dans la lutte contre les maladies infectieuses. Grâce à des politiques audacieuses, le Sénégal est devenu un modèle de leadership en santé publique pour le continent. L'histoire de l'Institut Pasteur est une histoire d'humanisme, de dévouement et d'innovation qui, comme le rappelait Madame Cissé, commence en 1896 avec la création du premier laboratoire de microbiologie en Afrique de l'Ouest par le docteur Émile Marchou, qui était un disciple de Louis Pasteur. Ce laboratoire menait aussi des recherches sur le paludisme et la fièvre jaune, sera transféré à Dakar sur le site actuel de l'Institut Pasteur en 1913 et va contribuer par la recherche et les mesures de prévention à l'amélioration des conditions sanitaires, mais aussi va participer activement à la formation des médecins et des techniciens locaux renforçant ainsi les capacités médicales de la région. En 1923, sous l'impulsion de l'Institut Pasteur à Paris, il est décidé de transformer ce laboratoire de Dakar en un véritable Institut Pasteur dont l'objectif était d'en faire un centre régional dédié à la lutte contre les maladies tropicales, à la production de vaccins, tout en poursuivant des recherches sur les maladies endémiques. En 1924, l'Institut Pasteur est officiellement inauguré avec une mission très claire: protéger la santé des populations d'Afrique de l'Ouest contre les maladies dévastatrices. Depuis ce jour, nous sommes restés fidèles à cette mission. Et pour mieux servir cette mission, l'Institut Pasteur de Dakar a connu au cours de ce siècle d'existence plusieurs réformes institutionnelles pour devenir en 2010 une fondation sénégalaise à but non lucratif et d'utilité publique. C'est grâce à cette structure de gouvernance que nous avons pu nous adapter aux défis sanitaires mondiaux tout en restant enracinés dans les besoins locaux, ce qui a permis bien évidemment de s'illustrer comme une belle réussite de la coopération franco-sénégalaise. Notre histoire est marquée par des jalons majeurs, comme l'isolement du virus de la fièvre jaune en 1927. C'est un des tout premiers virus qui a été isolé au monde, ce qui a conduit au développement du vaccin qui a été produit, comme le rappelait Mme Cissé, depuis 1937, faisant du Sénégal un des plus vieux producteurs de vaccins en Afrique et dans le monde, et le seul producteur préqualifié par l'OMS en Afrique. Ce vaccin a permis bien évidemment de sauver des millions de vies. L'élargissement aussi de nos travaux à des maladies telles que la méningite, la dengue, le choléra, l'Ebola, le Zika et plus récemment la COVID-19 ou la variole du singe, qui a conduit au déploiement d'une expertise pour soutenir au cours des 10 dernières années 40 des 54 pays africains et 2 pays d'Amérique du Sud. Ce travail a pu être fait grâce aux 16 centres de référence nationaux, régionaux ou mondiaux confiés par l'OMS, la FAO, l'Africa CDC ou l'OAS et qui font de l'Institut Pasteur de Dakar une ressource nationale, continentale et mondiale. Il faut rappeler aussi la mise en place de programmes de recherche et de santé publique innovants, comme le programme de Djelmo et de Ndiop, qui a permis de mieux comprendre le paludisme et d'autres maladies infectieuses. Le programme de surveillance de Kédougou, qui a permis d'identifier plus d'une vingtaine de nouveaux virus et anticiper sur les épidémies majeures comme celle du Zika en 2016, ou aussi le système 4S de surveillance syndromique que nous partageons avec le ministère de la Santé et qui est aujourd'hui étendu dans 8 pays de la sous-région ouest-africaine. Important de rappeler aussi la reconnaissance de nos travaux, de nos laboratoires ou de nos chercheurs par des prix internationaux prestigieux tels que le prix Galien Afrique, le prix Galien MedStartup des États-Unis ou des accréditations de référentiels pour les qualités les plus élevées telles que l'ISO 9001, 1589, bonne pratique de fabrication, 13485 et 17025. Enfin, la production de tests de diagnostic rapides et abordables pendant la pandémie de COVID-19 grâce à un modèle d'affaires innovant. Ces réalisations ne sont possibles que grâce à la collaboration entre nos chercheurs, nos partenaires et les communautés que nous servons. Nos partenariats avec le réseau des instituts Pasteur, les gouvernements, les agences des Nations Unies, les universités du Sénégal et du monde entier sont le fondement de ce succès. Nous avons collaboré avec des institutions telles que l'OMS pour répondre aux urgences. Le projet Madiba, notre nouvelle unité de production de vaccins à Diamniadio, est le fruit d'un partenariat public-privé soutenu très fortement par l'État et qui est très, très ambitieux, visant à garantir l'autosuffisance vaccinale en Afrique. Nos relations avec les laboratoires internationaux de plusieurs pays représentés ici nous permettent de rester à la pointe de l'innovation scientifique. Ces collaborations démontrent qu'ensemble, nous pouvons surmonter les défis les plus complexes. Les populations et les communautés que nous servons sont au cœur de notre mission et nos partenaires naturels. Sans leur confiance, leur coopération et leur soutien, notre travail serait impossible. Nous leur devons beaucoup et nous restons déterminés à renforcer ce lien indéfectible. Mesdames et messieurs, en regardant l'avenir, nous avons une ambition claire: bâtir un monde où la santé est accessible à tous, où les épidémies sont prévenues et contrôlées et où l'Afrique occupe une place centrale dans les innovations scientifiques. Dans le monde d'aujourd'hui, marqué par les crises sanitaires de plus en plus complexes, la souveraineté pharmaceutique et sanitaire est devenue un impératif stratégique pour toutes les nations, notamment africaines. Au Sénégal, les autorités ont fait le choix de ne plus dépendre exclusivement des chaînes d'approvisionnement mondiales pour répondre aux besoins critiques de nos populations. La pandémie de la COVID-19 a révélé une urgence de ce défi. Accéder rapidement à des vaccins, des médicaments et des diagnostics ne devrait plus être un luxe, mais juste une question d'équité. L'Institut Pasteur de Dakar, avec des projets et initiatives phares comme Madiba, comme Africa Maril, comme Diatropix, DAVAC, le Centre de recherche sur les vaccins, Kwame, CEDAR, Vaccine, incarne cette vision. C'est pourquoi nous nous engageons pour les prochaines décennies à produire localement les vaccins essentiels pour garantir une autonomie face aux épidémies et aux pandémies, de développer des outils de diagnostic adaptés, accessibles et abordables pour diagnostiquer rapidement les maladies émergentes, de faire des recherches sur les maladies émergentes. Nous continuerons ainsi à anticiper et répondre aux nouvelles menaces telles que les zoonoses et le changement climatique. Former et retenir les talents africains pour bâtir une expertise scientifique solide et durable sur le continent pour porter notre héritage encore plus loin. La souveraineté pharmaceutique et sanitaire n'est pas seulement une question de santé publique, mais aussi de sécurité mondiale, de diplomatie et de coopération internationale. Elle reflète notre ambition collective d'autonomiser le Sénégal et l'Afrique en leur donnant les moyens de protéger leur population et répondre efficacement aux crises et de s'affirmer comme des leaders dans le domaine de la science et de l'innovation. Nous avons la ferme volonté que notre avenir repose sur l'innovation scientifique, la solidarité et l'investissement dans nos capacités locales. L'Institut Pasteur de Dakar continuera d'incarner l'excellence dans tous ces domaines, avec le soutien de nos partenaires, de nos gouvernements, de nos communautés. Nous sommes prêts à relever tous ces défis. Mesdames et messieurs, je tiens à rendre hommage à celles et ceux qui, à l'Institut Pasteur, dans l'ombre ou la lumière, ont fait de cet institut ce qu'il est aujourd'hui. Je veux parler du personnel, aux générations précédentes, à nos valeureux retraités dont le travail acharné continue de nous inspirer, à nos directeurs qui servent avec générosité, dévouement et empathie la mission de l'Institut et dirigent avec efficacité nos équipes, à nos chercheurs et cadres scientifiques dont l'engagement indéfectible et la quête perpétuelle d'excellence ont permis des avancées remarquables dans la lutte contre les maladies infectieuses, à notre personnel technique et administratif qui veille chaque jour au bon fonctionnement de nos laboratoires, infrastructures et programmes. Votre dévouement, votre passion et votre résilience sont la pierre angulaire de notre succès. À travers vous, l'Institut Pasteur de Dakar rayonne en Afrique et dans le monde entier. Je tiens également à exprimer ma gratitude profonde aux deux personnalités exceptionnelles qui ont accepté de présider les festivités de notre centenaire. Le professeur Awa Maricol Seck, une championne de la santé publique au Sénégal et à l'international, dont la vision a profondément marqué le secteur de la santé dans notre pays et dans le monde. Le professeur Peter Piot, figure emblématique de la lutte contre les maladies infectieuses, dont l'expertise et le leadership inspirent notre communauté scientifique. Je voudrais aussi remercier particulièrement les trois présidents du conseil de fondation, M. Andri Asamoah, Dr Mam Tcherno Abissi, M. Elhaji, avec qui j'ai eu l'honneur et le privilège de travailler et qui m'ont toujours apporté leur soutien sans faille. Je voudrais exprimer une mention spéciale à l'équipe et au comité d'organisation de ce centenaire, coordonné par Mme Karine Bellondrade, qui ont traduit pendant toute cette année cette ambition en réalité. Pour conclure, mesdames et messieurs, ce centenaire est une occasion de célébrer un siècle de dévouement, de résilience et de progrès. Mais c'est également un appel à poursuivre notre mission avec la même passion et le même engagement. L'Institut Pasteur de Dakar est et restera un phare pour la science et la santé publique en Afrique et au-delà. Ensemble, avec nos partenaires, nos communautés et nos gouvernements, nous construirons un avenir où chaque vie, quelle que soit son origine, aura accès à une santé de qualité. Merci à toutes et tous pour votre soutien et votre confiance. Vive la science, vive la coopération internationale et vive l'Institut Pasteur de Dakar.
Merci au docteur Amadou Al-Fassal, administrateur général de l'Institut Pasteur de Dakar. C'est une figure emblématique dans le domaine de la santé mondiale. En tant que directeur exécutif fondateur de l'ONU-SIDA et sous-secrétaire général des Nations Unies, il a été le fer de lance de la lutte contre le VIH-SIDA, transformant la réponse mondiale et améliorant la vie de millions de personnes. Il a co-découvert le virus Ebola et a joué un rôle essentiel dans la lutte contre les pandémies mondiales, notamment la pandémie de COVID-19, où il a été conseiller spécial de la présidente de la Commission européenne, Ursula von der Leyen. Il préside actuellement le conseil scientifique de l'Institut Pasteur de Dakar ainsi que le conseil stratégique du Pasteur Network, mettant son expertise au service de l'innovation scientifique et du renforcement des systèmes de santé publique en Afrique. Je voudrais, s'il vous plaît, une ovation pour Sir Peter Piot.
Merci beaucoup. Et Monsieur le ministre de la Santé, l'Action sociale, Madame la ministre d'État, Sœur Awa-Marie Kolsek, collègue Amadou Al-Fassal, tous les dignitaires, comme on dit en anglais, all protocols observed. Je suis très honoré pour être ici et ravi en fait de participer à cette semaine qui n'est pas moins qu'historique. Pas la semaine, mais tout ce qui a été achevé et tous les plans qui vont être mis en place. Un centenaire n'arrive qu'une fois, par définition, et c'est un événement précieux qu'il ne faut pas rater, une occasion pour aussi bien célébrer mais surtout pour construire l'avenir et pour réfléchir à l'avenir. Un avenir qui est basé sur une fondation très solide dans le cadre de l'Institut Pasteur de Dakar. Et aller plus haut, toujours plus haut. C'est exactement l'agenda de cette semaine-ci. Et donc, la tentation de ces centenaires est toujours de parler du passé et tout ce qui a été fait et the best of. Mais maintenant, l'option était vraiment de s'orienter, de se concentrer sur l'avenir. Et à juste titre, la semaine commence par un symposium scientifique. Parce que la science a été la base et continue d'être la base des activités de l'Institut Pasteur, en plus de l'engagement pour une justice en matière de santé. Le palmarès de l'IPD n'est rien qu'impressionnant et je ne vais pas répéter ce que notre cérémonie nous a raconté et M. Amadou Sall. Mais il ne faut pas oublier non plus que, comparé à il y a 100 ans, le Sénégal, l'Afrique a fait d'énormes progrès en santé. Quand on voit que l'espérance de vie, il y a 100 ans, était dans les 30 années, c'était maintenant, même au Sénégal, on est presque, on a presque atteint 70 ans. La mortalité infantile et maternelle ont baissé. Je ne dis pas que tout ça, c'est grâce à l'Institut Pasteur. Non, c'est vraiment un effort collectif des gouvernements successifs, des communautés et de l'innovation technologique. et surtout les maladies qu'on peut prévenir par vaccination et par hygiène sont beaucoup moins un problème qu'avant. Mais en tant que président du conseil scientifique depuis presque 9 ans maintenant, j'ai eu le privilège d'observer la transformation de l'Institut et de l'appuyer avec notre comité. Et cette transformation s'est faite à plusieurs niveaux. Tout d'abord, je dois dire que une réaffirmation que l'Institut Pasteur de Dakar est une institution fondamentalement sénégalaise avec un mandat et une action qui, en premier lieu, est là pour la santé publique et le développement économique, je dirais, pour le pays, le Sénégal. Deuxièmement, un renforcement de la recherche scientifique, pas seulement dans les domaines classiques comme la virologie, qui est toujours un point très fort, mais aussi en y intégrant tout ce qui est maintenant à la pointe de la science et, par exemple, tout ce qui est digital, l'informatique et tout ça. Et ça, c'est un point fort. Et ce qui m'a impressionné, que c'est vraiment mené par des jeunes qui ont été formés à l'étranger, mais qui ont choisi de rentrer au pays et de vraiment développer cet aspect de la science qui sera essentiel pour un avenir fructueux. Troisièmement, même si dès le début, comme l'a dit Madou, la vocation était régionale dès le début, mais maintenant c'est régional au niveau continental. En tant que centre de référence du Africa CDC, mais aussi avec les interventions lors des épidémies. Le premier diagnostic d'Ebola en Afrique de l'Ouest, le premier diagnostic lors du début de la pandémie Covid, mais pas seulement au niveau du laboratoire, mais aussi avec des interventions sur le terrain. Et ça, c'est vraiment un développement nouveau que nous applaudissons. Et puis, il y a aussi un rôle mondial qu'il ne faut pas négliger. L'Institut Pasteur de Dakar est reconnu comme une référence, que ce soit à l'OMS, à Gavi pour l'immunisation, CEPI, et bien sûr jouant un rôle important dans le network, le réseau Pasteur, qui comprend plus de 30 instituts Pasteur dans le monde. Donc, ça a un impact impressionnant. Et cinquièmement, c'est la production de vaccins et de diagnostics. Bien sûr, l'Institut Pasteur de Dakar était déjà à l'avant-garde avec le lancement du premier vaccin contre la fièvre jaune, mais maintenant, un impact positif, je dirais, de la pandémie Covid, pour moi, c'est que en Afrique, pour la première fois, on n'a pas attendu la charité du Nord parce qu'elle ne viendrait pas, parce que le Nord était complètement envahi aussi par cette épidémie et même paralysé parfois. Et c'est, en fait, comme on dit en anglais, il faut jamais rater une crise, que construire sur ses atouts de science, de l'innovation, mais aussi la tradition de production de vaccins a permis à l'Institut Pasteur de Dakar d'être vraiment à l'avant-garde de la production de vaccins sur le continent et aussi de diagnostics, comme on le verra cette semaine-ci avec l'ouverture de 2 unités. Pour une grande partie, c'est grâce au leadership du professeur Amadou Al-Fassal, sa vision, sa crédibilité scientifique, Et je dirais que le parcours rien que remarquable et exceptionnel de ces 10 dernières années de l'Institut Pasteur de Dakar sont dus pour une grande partie à sa vision, ses dons de communication, mais aussi même de diplomatie, ce que peut-être Amadou va mettre en doute, mais il est vraiment devenu un des grands diplomates en santé mondiale. Un grand merci aussi, comme l'a dit Amadou, pour toute l'équipe. Avec le comité scientifique, on a eu beaucoup d'interactions avec les gens, les employés, les scientifiques, mais aussi les autres. Et je dois dire, leur engagement est rien que remarquable. Et je dois dire aussi que sans l'appui persistant et constant du gouvernement et des gouvernements, tout cela n'aurait pas été possible. Et encore un grand merci, Monsieur le ministre, d'être parmi nous et pour le reste de la semaine aussi. J'en profite aussi pour saluer mes deux amis de longue date, professeur Awa Kolsek, qui vraiment m'a inspiré beaucoup depuis des années. Quand ensemble, on était engagés dans la lutte contre le sida, ça fait, je ne vais pas mentionner combien d'années, mais ça fait longtemps, mais aussi avec qui j'ai travaillé étroitement à l'ONU-SIDA et puis après. Et aussi, le keynote speaker, le docteur Chikwe Ikweazu de l'OMS, qui est aussi un de nos grands leaders africains en santé publique. C'est aussi une occasion pour rendre hommage au professeur Cheikh Ibrahim Niang, qui vient de nous quitter il y a quelques semaines seulement, et qui est un des grands anthropologues africains. Et pour moi, le fait qu'il était qu'il travaillait avec l'Institut Pasteur de Dakar est une illustration de l'approche multidisciplinaire de l'Institut. Et ça aussi, c'est une transformation qui n'existait pas avant. Et ce sera essentiel pour s'attaquer aux grands problèmes. Je suis convaincu que l'Institut Pasteur de Dakar est à la hauteur des défis qui s'annoncent. Le Sénégal, l'Afrique et le monde auront besoin de l'Institut Pasteur de Dakar pour encore 100 ans, je crains. Et tout d'abord, il y a un agenda non achevé, inachevé. On a toujours le paludisme, on a toujours le VIH, la tuberculose et d'autres. Il y a toujours des femmes qui meurent en donnant naissance. Donc, il y a encore du travail à faire de ce côté-là. Mais le monde et la santé publique continuent à changer. Pour du bien, pour du mal. Et je dis toujours que le changement est la seule constante à la vie. Donc, il faut en être conscient et agir. Et permettez-moi de mentionner 3 avant de conclure, avec impact sur la santé. Il y a bien sûr le changement climatique et qui a déjà un impact direct sur le domaine classique de l'Institut Pasteur de Dakar, par exemple les transmissions, les infections de virus par anthropodes, par insectes. Mais il y a beaucoup d'autres impacts. Deuxièmement, c'est les maladies non communicables, c'est-à-dire qui est le thème, un des thèmes principaux du Forum gallien, présidé par la professeure Marie Kolsek, et qui maintenant, bientôt, je crois, seront responsables pour la majorité des maladies et la mortalité des gens, y compris en Afrique. Et quand on pense au diabète et maladies cardiovasculaires, et ça c'est un grand défi et c'est une question, qu'est-ce qu'on peut faire? Il y a la prévention, mais il y a aussi des actions. Et troisièmement, la bonne nouvelle, c'est qu'on vit tous beaucoup plus longtemps, mais pas forcément en bonne santé. Et ça représente aussi des défis, aussi bien économiques, bien sûr, mais aussi de santé. Et c'est lié aussi aux maladies non communicables. Mais c'est aussi des opportunités. Et en parlant d'opportunités, j'en vois trois aussi. D'un côté, il y a les deux technologies de pointe de notre époque. C'est la biotechnologie, et là, l'Institut Pasteur de Dakar est bien placé, et mercredi, il y a une journée sur l'innovation, et qui va vraiment parler en détail de ça. Et deuxièmement, c'est la transformation digitale. Si ce n'est que le téléphone mobile, mais tout ce qui est intelligence artificielle, etc. Et ça sont de grandes opportunités pour en fait faire avancer la santé et la recherche, y compris en Afrique, et peut-être plus qu'ailleurs. Et ce qui me rend vraiment heureux, c'est ça fait maintenant, il y a 2 ans, je pense, qu'il y avait les Grand Challenges, les Gates Grand Challenges, ici à Dakar, et que il y avait des dizaines de jeunes Africains qui venaient avec des idées, des start-up en intelligence artificielle. Et pour moi, ça, c'était un des moments, des grands moments que j'ai eu sur ce continent, que ça c'est l'avenir. Et troisièmement, et ça va être illustré aujourd'hui et demain, il y a des centres d'excellence en matière scientifique en Afrique, un peu partout, bien sûr ici. Et ça aussi, c'est une garantie pour vraiment pour qu'il y ait des solutions africaines qui vont être trouvées ici. Donc, je crois que l'avenir est vraiment, il faut l'aborder avec de l'optimisme, même s'il y a beaucoup de défis, et surtout si l'Institut Pasteur de Dakar et d'autres s'allient aux partenaires partout en Afrique et ailleurs, comme le Pasteur Network, on en a entendu, mais aussi par d'autres qu'on entendra aujourd'hui. En conclusion, le message très fort de ce centenaire, de cette semaine riche en événements et idées, est clair. L'Afrique est en train de devenir de plus en plus compétitive en matière de sciences de haute qualité. Ce n'est plus seulement une destination pour des recherches, pour des découvertes faites ailleurs, mais l'Afrique est à l'origine aussi de découvertes originales. Maintenant, il faut traduire ça en innovation et en produits aussi sur le continent. Et deuxièmement, ce qui me rend optimiste, c'est un avenir où il y aura aussi un avenir de ce qu'on appelle la souveraineté et la sécurité sanitaire par la production de produits médicaux sur le continent. Pour moi, c'est beaucoup plus important que n'importe quel traité international, parce que c'est ça ce qui garantira l'accès aux produits et aux soins. Un grand merci et je vous souhaite une bonne semaine.
Merci, professeur Peter Piot, président du conseil scientifique de l'Institut Pasteur de Dakar et du conseil stratégique du Pasteur Network. En faisant mes recherches hier pour la préparation de ce centenaire de l'Institut Pasteur de Dakar, j'ai découvert un nouveau titre, une nouvelle fonction que je ne connaissais pas, le titre de ministre du Monde. La dame que je m'en vais vous présenter tout de suite a été nommée meilleure ministre du monde à Dubaï en février 2017 lors du sommet mondial des gouvernements. Médecin spécialiste des maladies infectieuses et de bactériologie, virologie, elle a eu à diriger le département des maladies infectieuses de l'université Cheikh Anta Diop de Dakar. Ancienne ministre du Sénégal, ancienne ministre d'État du Sénégal auprès du président de la République, elle est présidente de l'association Galien Africa qui porte entre autres l'organisation annuelle du Forum Galien et du prix Galien Afrique. Cette grande dame a été directrice exécutive du partenariat Rollback Malaria et directrice du département des politiques, stratégies et de la recherche de l'ONU-SIDA. Elle est membre des jurys du prix Noguchi Afrique, du prix Virchow et du prix des jeunes innovateurs africains pour la santé. Lauréate de plusieurs prix prestigieux, elle est chevalier de l'ordre du mérite du Sénégal, de la Gambie et du Burkina Faso. Et comme c'est une dame, je vais vous demander d'applaudir encore beaucoup plus pour le professeur Eva Marie Colson.
Merci beaucoup, Madame, on dit le ou la Master of Ceremony. Merci beaucoup à toutes les personnes qui sont présentes. Monsieur le ministre de la Santé et de l'Action sociale, Excellences, Mesdames, Messieurs les ministres, honorables députés, Excellences, Mesdames et Messieurs les ambassadeurs, Mesdames et Messieurs les directeurs généraux, Mesdames et Messieurs les représentants des institutions internationales, Mesdames, Messieurs les professeurs, distingués invités, chers partenaires, chercheurs, membres du personnel et amis de l'Institut Pasteur de Dakar, Mesdames et Messieurs, en vos rangs, titres et qualités. Permettez-moi de vous saluer chaleureusement et de vous remercier d'être présents aujourd'hui pour célébrer ensemble un moment historique, le centenaire de l'Institut Pasteur de Dakar. Cet événement exceptionnel est bien plus qu'une célébration. C'est un témoignage vivant d'un siècle d'engagement indéfectible envers la santé publique, l'innovation scientifique et la solidarité humaine. Il est également l'occasion de reconnaître et de remercier toutes les femmes et tous les hommes passés et présents qui ont contribué à façonner cette prestigieuse institution et à écrire son histoire extraordinaire. Je voudrais rendre un hommage particulier au professeur Peter Piot, président du conseil scientifique de l'Institut Pasteur et du réseau Pasteur, mais également quelqu'un qui n'est pas là aujourd'hui, monsieur Elhachi, président du conseil de fondation. Ils ne sont plus à présenter. Nos chemins se sont croisés à plusieurs reprises et nous nous retrouvons encore aujourd'hui, toujours déterminés à nous battre pour la santé mondiale en général, celle des populations africaines et celle du Sénégal en particulier. Je suis fière de vous compter parmi mes amis, mes frères, et je vous renouvelle toute mon affection. Nous ne pourrions évoquer l'histoire de l'Institut Pasteur de Dakar sans souligner l'impact profond et durable du docteur Amadou Alpha Sall, incarné par son altruisme, son humilité, ses valeurs et l'excellence de son parcours. Il est un véritable bâtisseur de notre époque. Qu'Allah le Tout-Puissant continue de vous accompagner et de guider vos pas. Amin. Depuis sa fondation, l'Institut Pasteur de Dakar s'est illustré comme un pionnier de la santé publique en Afrique et dans le monde. Parmi les contributions les plus marquantes, je voudrais rappeler, et on l'a dit à plusieurs reprises déjà, la fabrication au Sénégal du vaccin contre la fièvre jaune. Cette expertise a permis de sauver, et on le dit régulièrement, et si l'on tient compte de tout ce qui s'est fait depuis plusieurs années, effectivement sauver des millions de vies. L'Institut Pasteur de Dakar ne s'est pas limité à la recherche et à la production de vaccins. Il a joué un rôle central dans la réponse aux épidémies, notamment en formant des équipes capables de répondre rapidement et localement aux urgences sanitaires. Son action lors de la pandémie à la COVID-19 est un exemple remarquable. Comme je l'ai personnellement constaté, et je peux dire vécu. Sous le leadership éclairé du professeur Amadou Alfassal, l'Institut Pasteur de Dakar a eu non seulement à diagnostiquer rapidement la maladie, mais aussi à partager son savoir-faire avec d'autres pays africains en formant des spécialistes dans plus de 20 pays. Lors de la première édition du prix Galien Afrique en 2021, un jeune chercheur de l'Institut Pasteur de Dakar, Cheikh Tidiane Diagne, a été honoré pour sa contribution significative au développement du test diagnostic de la COVID-19. Je suis heureuse d'apprendre qu'il est aujourd'hui leader et directeur d'un site que nous allons visiter dans la semaine. C'est dire donc que les jeunes deviennent aussi, à un moment donné de leur vie, des responsables. Et voilà un exemple qui me semble être important. L'Institut Pasteur a également été toujours proche des communautés, intégrant les besoins locaux dans ses priorités et démontrant qu'une science de qualité doit avant tout être au service des populations. Un siècle d'impact n'aurait pas été possible sans la collaboration étroite avec des partenaires visionnaires dont je reconnais certains dans la salle. Alors que nous célébrons cet héritage exceptionnel, il est essentiel de tourner notre regard vers l'avenir. L'Institut Pasteur de Dakar s'engage aujourd'hui dans une mission stratégique, renforcer la souveraineté sanitaire, vaccinale, pharmaceutique en Afrique. Des projets comme le Madiba Vaccine Project marquent une étape décisive vers une indépendance sanitaire en permettant au continent de produire localement des vaccins de qualité pour protéger nos populations, mais également celles d'ailleurs. Ce vaccinopole incarne une vision exceptionnelle, celle d'une Afrique qui investit dans sa propre santé, réduit sa dépendance extérieure et bâtit un avenir où chaque citoyen, du nord au sud, aura accès à des soins de qualité. Parallèlement, des initiatives comme Diatropix, spécialisées dans le diagnostic rapide et accessible, ou encore le Centre pour la résilience aux épidémies en Afrique, CARE, dédié à la formation des futurs leaders en santé publique, démontrent la capacité de l'Institut Pasteur qui s'investit dans tout ce qui est humain. Cependant, pour réussir cette transformation des crises sanitaires en opportunités, une approche collaborative, inclusive est essentielle. L'Institut Pasteur de Dakar continuera à avoir des besoins importants et aussi de l'appui des gouvernements, du secteur privé, des bailleurs internationaux et des communautés, et surtout de l'engagement des jeunes. C'est ensemble que nous pourrons bâtir cet élément important du système de santé résilient, capable de répondre aux défis actuels et futurs. Mesdames et messieurs, chers amis, en célébrant ces 100 ans d'excellence de l'Institut Pasteur de Dakar nous permet de rendre hommage à son passé glorieux, mais également nous lançons une invitation à participer activement à la construction des 100 prochaines années. Cette institution, aujourd'hui fondation sénégalaise, a prouvé qu'elle pouvait être un modèle d'innovation et de résilience, non seulement pour l'Afrique, mais pour le monde entier. C'est à nous tous, en tant qu'acteurs et partenaires, de poursuivre cette mission, de garantir que les générations futures continueront à bénéficier de cette vision audacieuse et humaine. À vous, les jeunes chercheurs, étudiants et professionnels de la santé, mais également professionnels d'autres secteurs, puisque nous avons bien appris avec l'Institut Pasteur aussi que la recherche et les actions doivent se baser sur une multidisciplinarité. Je terminerai donc lançant un appel à ces jeunes. Inspirez-vous de cet héritage centenaire. Vous êtes les artisans du futur. Soyez audacieux. Portez haut les valeurs de partage et d'innovation et construisez un monde où la santé publique sera synonyme d'équité, de progrès et d'espoir pour tous. Je vous remercie.
Merci au professeur Eva Maricol Sec, présidente du Forum Gallienne Africa, ancienne ministre d'État auprès du président de la République et coprésidente de la célébration du centenaire de l'Institut Pasteur de Dakar. Je vous le disais tantôt à l'entame de ma prise de parole ce matin, nous célébrons, mesdames et messieurs, l'excellence. L'excellence n'est jamais un accident. Elle est toujours le résultat d'une intention élevée, d'un effort sincère, d'une exécution intelligente. La personnalité qui va à présent prononcer le discours principal de cette cérémonie d'ouverture est épidémiologiste, auteur de plus de 150 publications sur les maladies infectieuses. Directeur exécutif adjoint du programme des urgences sanitaires à l'Organisation mondiale de la santé, il a été auparavant directeur général du Centre nigérian de contrôle des maladies. Il a managé diverses agences nationales de santé publique, notamment le NICD en Afrique du Sud, l'Agence de protection de la santé du Royaume-Uni, ainsi que l'Institut Robert Koch d'Allemagne. Titulaire d'un doctorat honorifique en sciences de la Liverpool School of Tropical Medicine, il est chevalier de l'Ordre du mérite de la productivité nationale du Nigeria, un titre décerné par le président de la République pour ses innombrables services en matière de santé publique. Docteur Chikwe Yekwiazu, vous êtes invité à nous rejoindre sur le présidium pour prononcer votre discours principal.
Merci beaucoup. But that's the end of my French for today. But so please bear with me. Honorable Minister of Health, Dr. Ibrahima C. Thank you very much. It's really an honor. And I think on behalf of Amadou and myself, I'll say it's a real honor to share a platform with Professor Awa Kolsek and Professor Peter Piot. These are elders in the profession. And in my place in Nigeria, they say when children wash their hands properly, you're allowed to eat with the elders. So today we're really privileged to share the platform with you. And I hope that you're slightly proud of your legacy in building the next generation. So, distinguished guests, esteemed colleagues, partners, dear friends, good morning. It's truly an honor to join you today to celebrate this incredible milestone, the 100th anniversary of Institut Pasteur de Dakar, a symbol of scientific excellence and innovation, and a source of immense pride for the continent. I extend greetings and offer congratulations from our Director General, Dr. Tedros Ghebreyesus, and Dr. Mike Ryan, Executive Director of WHO's Emergencies Program, Health Emergencies Program. We are together proud of IPD's remarkable history and the strong partnership between WHO and IPD. We all recognize and are grateful for the profound impact that this institution has had on global health. I would like to specifically recognize and appreciate the government of Senegal for its continued commitment to IPD. The announcement just last week that the National Regulatory Authority of Senegal is now at maturity level 3 goes to show the government's general commitment to the development of this space. This would not be possible without the leadership and work of the colleagues from the Ministry of Health, the regulatory agencies, and many others in government. I can see in the audience many friends and colleagues from across the world, which points to the incredible work that IPD is doing for national, regional, and global health security. So I thought to focus my remarks on how we can contribute to a world with more institutions like the one that we are celebrating today. Like several of you in this room, we at WHO have a long-standing relationship with IPD. Since its designation as a WHO Collaborating Center for Arboviruses and Viral Hemorrhagic Fevers in 1963, IPD has been a critical driver of our efforts to protect the world from health threats. Our collaboration would not be possible without the scientific excellence that IPD brings, as well as trust and mutual respect between both institutions. There are several achievements I would like to highlight today. One of the most notable is IPD's role as the only manufacturer of a WHO pre-qualified yellow fever vaccine on the African continent. Since 1966, IPD has been at the forefront of yellow fever prevention, producing vaccines that have protected millions of lives, not only in Africa, but around the world. This is a legacy that continues to save lives today. It is also the foundation on which IPD is now building further to strengthen access to vaccines in the region and beyond. IPD's influence extends far beyond the borders of Senegal. It has become a vital resource for the African continent and a trusted partner to WHO in addressing some of the most pressing public health challenges of our time. Through its collaboration with WHO, the Global Outbreak Alert and Response Network, and other global health networks, IPD has supported several African countries. Its contributions span the full spectrum of emergency response, from diagnostics and outbreak investigations to vaccine development and training. This level of impact is unparalleled, and it speaks to the depth of expertise and the commitment within this institution and its leadership. In my previous role as DG of the Nigeria Center for Disease Control, we benefited from this expertise on several occasions, and the collaboration led us to doing cutting-edge work together on many outbreaks that we faced, from yellow fever to Lassa and Mpox. I remember vividly when we detected the first re-emergent cases of Mpox in Nigeria in 2017. And the quiet and effective collaboration that led to the publishing of the first sequencing results in a couple of weeks after the first case. These results enabled us to identify clusters of cases and understand transmission patterns. It was an immense source of pride that NCDC and IPD published these results together, an excellent example of regional collaboration. But it was not always easygoing. Amadou and his team set the bar very high. In Nigeria, we were often challenged, including by my minister at the time, on the need to build our own local laboratory capacity to match the capacity at IPD. During the West African Ebola outbreak in 2014 to 16, a period where countries like Liberia, Sierra Leone, and Guinea were hugely challenged by what was an unprecedented outbreak, WHO relied on IPD to provide lab and epidemiological support to the affected countries. Whenever we asked IPD for support, they were willing and able. And it was really great for us at WHO to be able to support this South-South collaboration. This scenario of IPD supporting other countries has played out on many outbreaks since. Just recently, during the Marburg virus outbreak in Equatorial Guinea, IPD's laboratory and sequencing capabilities were instrumental in enabling us to understand the series of events and ultimately in containing the outbreak. But it wasn't only outbreak response. IPD has also been on the forefront of efforts to combat arboviruses such as dengue, chikungunya, and yellow fever, and the institution's leadership in genomic analysis of pathogens causing these diseases have advanced our understanding and enhanced our ability to respond. The COVID-19 pandemic was a defining moment for the world and, of course, for IPD. In this unprecedented crisis, IPD again rose to the challenge, demonstrating its capacity to lead in times of uncertainty. As one of the only 2 labs in Africa initially designated by WHO to train other countries in COVID diagnostics, IPD trained professionals from 25 countries, building critical capacity across the continent. I remember at the time in the early weeks of February, when we sent our laboratory scientists from Abuja to Dakar to be trained in the very first methods that we knew how to use on diagnostics for COVID. And many other countries on the continent benefited from this. Beyond training, IPD's contributions to genomic surveillance, rapid diagnostic test manufacturing, and seroepidemiological studies were transformative for the global response. IPD also played a key role in several WHO-led initiatives, such as clinical trials and expert groups on COVID-19. These efforts were not limited to the region, they had a global impact, showcasing the ability of African institutions to lead on the global stage. Today, as IPD grows in Dakar, so does the WHO. Our new health emergency hub here in Dakar is already collaborating with IPD on many fronts, co-hosting critical meetings, developing opportunities in genomics, and building capacity for the region. Now to a topic that is very dear to me. Today, we're celebrating this remarkable institution, which we are all proud of and are witnesses to its achievements. However, the question that has been on my mind as I travel to Dakar, and perhaps for all of us collectively, is how do we build more institutions like IPD that will respond to today's crisis and at the same time lay the foundation for long-term resilience and health security, especially on our beloved continent. IPD is an exemplar of what can be achieved through strong, locally led institutions. This is clearly demonstrated in its 100 years of history, but more so in how it is shaping the future. IPD's success story shows that when investments are made in research, infrastructure, and leadership, the results can be transformational. Today, there are several discussions going on about local vaccine manufacturing capacity and building more institutions like IPD in the region. While improved vaccine security is critical for our region, the breadth of capability that we have to build, necessary for supporting the manufacturing ecosystem for all biologicals. IPD has provided us with a model that could serve as a blueprint for other countries and institutions to replicate in their own context, ensuring that they respond to both the immediate crisis that we face and our long-term challenges. On the African continent, our own countries must themselves invest in this space. While we are grateful for the support received, for too long on the continent, many of our countries have relied too heavily on aid to drive the development of critical research and public health infrastructure. This dependency has led to a situation where local research institutions are often underfunded and underdeveloped, leaving them ill-prepared to take on critical roles in advancing knowledge and innovation. This lack of strong local institutions across the continent becomes particularly evident when clinical trials and other research efforts are needed. This reinforces the cycle of dependency. It is this cycle that we're challenging IPD to break, and one that we must collectively support. We have a model here in IPD. The answer lies in investing in local capacity building, from strengthening research institutions to ensuring that researchers have the training, the resources, and opportunities that they need to lead and drive innovation. Engaging local institutions in research from the outset, whether in study design, implementation, or analysis, can ensure that the research is contextually relevant and the benefits are felt at the local level. These institutions need to be enabled by strong leadership and sustainable financing. Today, IPD is not just providing important public health services, but also serving as an innovation hub, a training center, and truly a model institution for the region. This perfectly aligns with WHO's vision of a future where strong local institutions play the central role in health security. WHO's role, our desired role, is to support and empower institutions like IPD. As we celebrate IPD centenary, we must look to the future. The Madiba project is a bold and visionary initiative that promises to transform vaccine manufacturing in Africa. By focusing on R&D and training in biomanufacturing, Madiba is setting the stage for a future where Africa is not only prepared for pandemics, but is a global leader in vaccine production. The establishment of the Center for Resilience to Epidemics Care training center at the new rapid diagnostic test manufacturing facility with Diatropics are further examples of IPD's commitment to innovation and resilience. These initiatives will strengthen Africa's health systems and ensure that our continent is better prepared to respond to epidemics. On a personal note, I have witnessed firsthand the extraordinary work of IPD through its collaboration with other institutions on the continent in response to many outbreaks. Particularly, I reminisce about our collaboration to support Africa CDC on the COVID-19 response under the leadership at the time of Dr. John Nkengasong. Early in the pandemic, John would convene Amadou, myself, and a few other leaders in global health to brainstorm on some of the pressing and most difficult decisions of those days. Together, we shaped the early response on the continent, forming a thought leadership group for mutual support, always working in strong alignment with global leadership of WHO at the time. These partnerships exemplify the strength of regional and global networks in addressing public health challenges. As I conclude, I would also like to personally acknowledge the leadership of my dear brother, Dr. Amadou Sall. His tenure as the chair of the Global Outbreak Alert and Response Network Steering Committee was marked by significant contributions to outbreak response and global laboratory systems. Under his guidance, IPD has continued to thrive, setting new standards for excellence in public health. But most important to me, as I prepared for this meeting, I reviewed the messages I have exchanged with Amadou over the past 10 years. They show a relationship of trust and hope. We share a commitment to science and a progressive future for our beloved continent. But this will not happen by accident. It will only happen if we do not drop the ball and we keep pushing every day of the year to not only be recipients of aid, but to be co-creators of our desired future. To Dr. Sall, the IPD team, the government of Senegal, I extend WHO's deepest gratitude and congratulations. Your work has transformed lives and strengthened communities. It continues to inspire all of us. As we look to the future, let us recommit ourselves to supporting institutions like IPD, ensuring that they remain at the forefront of global health. Together, we can build a world where all people have the opportunity to lead healthy and fulfilling lives. On behalf of the World Health Organization, I wish IPD continued success in the years to come. May the next century be marked by even greater achievements, deeper partnerships, and a shared commitment to health equity. Congratulations and happy centenary. Thank you very much.
Thank you, Dr. Chikwe Yekweazu, directeur général adjoint pour les systèmes d'intelligence et de surveillance des urgences sanitaires à l'Organisation mondiale de la santé. Avant d'inviter le Dr. Ibrahim Assi, ministre de la Santé et de l'Action sociale, à prononcer son discours de clôture, mesdames et messieurs, nous allons à présent vous montrer comment l'Institut Pasteur de Dakar n'a cessé de se développer pour le bénéfice des populations depuis sa fondation en 1896. Et oui, nous avons conscience d'être en présence d'une audience composée en grande majorité de scientifiques, et comme les scientifiques sont comme Saint Thomas, ils ne croient que ce qu'ils voient. Eh bien, nous allons tout de suite vous montrer en images comment l'Institut Pasteur de Dakar inspire, éduque, attire des femmes et des hommes de sciences passionnés et visionnaires pour développer des solutions significatives aux problèmes de santé publique en Afrique. Nous allons donc projeter une vidéo réalisée avec l'appui d'un personnel engagé et dévoué à la tâche. C'est le lieu, encore une fois, de remercier ces femmes et ces hommes qui font l'Institut Pasteur de Dakar et qui œuvrent au quotidien à l'amélioration de la santé humaine au Sénégal, mais aussi en Afrique. Bonne projection et on se retrouve tout de suite.
À la pointe de l'Afrique de l'Ouest, l'histoire rencontre l'innovation et les efforts visant à améliorer la santé publique en Afrique prennent forme. En 2024, nous célébrons notre 100e anniversaire. Notre engagement est de promouvoir un avenir meilleur pour la santé publique africaine et de devenir un champion de la sécurité sanitaire en Afrique. Rejoignez-nous pour célébrer un siècle de progrès, un siècle de dévouement et un siècle d'impact dans la vie de millions de personnes. Un siècle de lutte contre les maladies infectieuses sur le continent africain grâce à la surveillance, à la recherche et à la fabrication d'une large gamme d'outils de santé. Institut Pasteur de Dakar, un siècle de dévouement, d'engagement sans faille et de travaux menés sur fond d'innovation. Depuis sa création en 1924, l'Institut Pasteur de Dakar est à la pointe de la lutte contre les maladies infectieuses. À la suite de la pandémie de Covid-19 et compte tenu de l'inégalité frappante que celle-ci a mise en évidence, l'Institut Pasteur de Dakar, IPD, a entamé une transformation pour assurer un avenir meilleur à la santé publique en Afrique et devenir un champion de la sécurité sanitaire de l'Afrique. Depuis 100 ans, l'Institut Pasteur de Dakar travaille sans relâche pour améliorer la santé publique. Nos équipes mènent des recherches biomédicales, fabriquent des vaccins et des produits de diagnostic, participent à des activités de santé publique, effectuent une surveillance épidémiologique et répondent aux épidémies. L'institution donne également la priorité à l'éducation, à la formation et à la fourniture de solutions de santé avec des laboratoires spécialisés pour répondre aux besoins de santé de la communauté. À l'Institut Pasteur de Dakar, nous sommes fiers de notre rôle de leader dans la biofabrication de vaccins et de tests de diagnostic. En tant que seule usine préqualifiée par l'OMS dans la région, nous disposons d'un solide historique d'excellence. Depuis près de 80 ans, nous fabriquons le vaccin contre la fièvre jaune depuis notre découverte du virus en 1927. Notre engagement inébranlable à produire des vaccins et des tests de diagnostic de premier ordre garantit la santé et le bien-être de notre communauté. L'IPD est une force majeure dans la protection de la santé publique et des communautés. Il joue un rôle crucial dans la surveillance et le diagnostic régionaux, et dans plus de 22 pays africains à détecter et à gérer les épidémies. Les pôles de recherche de l'IPD, notamment en virologie, immunologie, zoologie médicale, microbiologie et épidémiologie, sont à l'origine de percées biomédicales. Leur engagement à développer des vaccins pour la population africaine nécessite un large portefeuille, axé sur des vaccins d'importance régionale, utilisant des technologies pionnières telles que la culture cellulaire et l'ARNM. Encourageant un environnement d'inclusion, d'égalité des sexes et d'innovation, nous nous engageons à former la prochaine génération de scientifiques et d'autorités de santé publique. Chaque année, nous accueillons pas moins de 50 étudiants en master et doctorat. L'IPD se concentre sur les besoins de la région à travers nos plateformes scientifiques, telles que le Centre pour la résilience africaine aux épidémies, CARE, et le projet Kwame de formation des individus à la biofabrication. L'Institut Pasteur de Dakar propose également des solutions santé et des laboratoires spécialisés. Nous offrons des services de première classe, depuis les diagnostics cliniques, les analyses biologiques, les vaccinations, jusqu'aux tests de sécurité alimentaire. L'Institut Pasteur de Dakar est composé de leaders et de talents aux expériences diverses qui sont unis par un objectif commun. Créer une société dans laquelle chacun a accès aux soins de santé, quel que soit son lieu de résidence ou son niveau de revenu. L'Institut Pasteur de Dakar collabore avec ses partenaires et toute la communauté scientifique mondiale pour promouvoir des solutions de santé accessibles, durables et abordables au Sénégal, en Afrique et dans le monde.
Cent années de présence d'un petit laboratoire de microbiologie à Saint-Louis en 1896. L'Institut Pasteur de Dakar, c'est aujourd'hui, mesdames et messieurs, 87 ans de production de vaccins. Vous pouvez applaudir. 31 sites sentinelles de surveillance, 12 laboratoires de référence nationaux, régionaux et mondiaux, 50 étudiants en master et doctorants, 40 pays soutenus pendant les épidémies et plus de 120 partenaires à travers le monde. Ils sont nombreux, ces partenaires en tête de peloton. Naturellement, l'Organisation mondiale de la santé, qui depuis 50 ans appuie l'Institut Pasteur de Dakar pour atteindre les standards requis dans les domaines de la recherche. Les remerciements de l'Institut Pasteur de Dakar vont également à Africa CDC, qui s'évertue depuis sa création à renforcer les capacités des institutions africaines de santé publique. L'IPD Pasteur salue le travail du Centre CARE, inauguré il y a tout juste un an. Le Centre pour la résilience face aux épidémies en Afrique a pour objectif de former la prochaine génération de dirigeants, de décideurs et d'acteurs impliqués sur les fronts épidémiques. Enfin, l'Institut Pasteur de Dakar rend hommage à l'État du Sénégal à travers le ministère de la Santé et de l'Action sociale, ministère de tutelle de l'Institut et co-organisateur clé de cet événement qui nous réunit ce matin, ministère qui depuis sa création lui permet de pérenniser mais aussi d'accroître son activité. Le ministère de la Santé et de l'Action sociale est représenté ici par le docteur Ibrahim Massi, ministre de la Santé et de l'Action sociale. Pour le présenter, nous dirons que Dr Ibrahim Massi est professeur et maître de conférences en géographie à la santé à l'université Cheikh Anta Diop de Dakar, chercheur associé au Centre de surveillance écologique à Dakar. Après un doctorat en géographie de la santé à l'université Louis Pasteur de Strasbourg, il a travaillé au sein de plusieurs institutions internationales, notamment à l'université de Strasbourg, l'Institut national de recherche en santé publique en Mauritanie, le Centre suisse de recherche scientifique en Côte d'Ivoire, l'Institut tropical et de santé publique suisse avant de rejoindre l'université Cheikh Anta Diop de Dakar en 2017. Dr Si possède plus de 13 années d'expérience en tant qu'expert international en environnement, climat et santé, ayant collaboré avec des organisations telles que l'Organisation mondiale de la santé, le Fonds mondial, l'UNICEF, l'AFD et Save the Children. Dr Ibrahim Massi, vous êtes invité au pupitre pour prononcer le discours de clôture de cette cérémonie marquant le centenaire de l'Institut Pasteur de Dakar. Sous vos applaudissements.
Merci beaucoup, Madame la maître de cérémonie. Je vois que si vous continuez comme ça, bientôt vous allez rejoindre le concert des grands scientifiques de ce pays. Dire aussi qu'il sera difficile quand même de délivrer un discours à la hauteur de tout ce que j'ai eu comme mot d'introduction, parce que j'ai la lourde charge de faire les remarques, mais aussi de déclarer le discours de lancement de ce centenaire de l'Institut Pasteur. Mais je vais m'essayer. Excellences, Mesdames, Messieurs les représentants des ministres de la République, Mesdames, Messieurs les ambassadeurs ou les représentants des ambassadeurs, Monsieur le directeur de cabinet du ministère de la Santé et de l'Action sociale, Madame la présidente du Forum Galien Afrique, professeur Awa Maricol Seck, Monsieur le représentant de l'Organisation mondiale de la santé, Monsieur l'administrateur général de l'Institut Pasteur, Mesdames, Messieurs les ambassadeurs et les représentants des ambassadeurs, Mesdames, Messieurs les conseillers techniques, Mesdames, Messieurs les directeurs généraux nationaux et régionaux, Mesdames, Messieurs les représentants des universités, Mesdames, Messieurs les chefs de service, Mesdames, Messieurs les partenaires techniques et financiers du Sénégal, distingués invités en vos rangs, grades et qualités. C'est pour moi un immense plaisir que je prends la parole aujourd'hui à l'occasion de cette cérémonie exceptionnelle qui marque le centenaire de l'Institut Pasteur de Dakar. Un joyau scientifique et un pilier important de notre système de santé publique. Depuis un siècle, l'Institut Pasteur de Dakar s'est illustré par sa contribution inestimable à la recherche biomédicale, à la surveillance des maladies infectieuses et à la prévention des épidémies. En ce jour mémorable, nous célébrons non seulement les réalisations passées, mais aussi la vision et le courage de ceux qui, en 1924, ont posé les bases d'une institution devenue un symbole d'excellence scientifique en Afrique et dans le monde. Permettez-moi d'exprimer ma gratitude à toutes les équipes passées et présentes qui ont consacré leur énergie et leur expertise à sauver des vies. Ces hommes et ces femmes, animés par la passion et l'engagement, ont permis à l'Institut Pasteur de Dakar d'être à l'avant-garde de la lutte contre des fléaux tels que la fièvre jaune, la méningite, l'Ebola et plus récemment la pandémie de COVID-19. Mesdames, Messieurs, distingués invités, cet anniversaire est aussi l'occasion de réfléchir sur l'avenir et la contribution des scientifiques à la matérialisation du changement systémique appelé dans le nouveau référentiel des politiques publiques, l'agenda national de transformation Sénégal 2050. Nous sommes conscients que les défis sanitaires à venir exigeront des réponses innovantes, une collaboration renforcée et un investissement accru dans la recherche et les infrastructures sanitaires. Le Sénégal est fier de pouvoir compter sur l'Institut Pasteur pour accompagner cette dynamique, notamment à travers le développement local de vaccins et de technologies de diagnostic qui sont essentielles pour asseoir la souveraineté sanitaire de notre continent. En célébrant ce centenaire, les autorités sénégalaises, à travers son Excellence, le président Bassirou Diomaye Diakhar Faye et son Premier ministre, M. Ousmane Sonko, renouvellent leur engagement à bâtir un système de santé inclusif, résilient, équitable et contributif à la couverture sanitaire universelle. Cette commémoration est également une opportunité pour rendre un hommage à des générations de chercheurs, de médecins, de scientifiques qui ont fait de cet établissement un symbole de l'innovation médicale africaine. Leur travail a sauvé des millions de vies au Sénégal et bien au-delà de nos frontières. Je tiens également à remercier les partenaires nationaux et internationaux qui, depuis un siècle, soutiennent les efforts de l'Institut. Votre engagement est une preuve que la santé est un bien commun qui transcende les frontières et que seule une solidarité mondiale permettra de relever les défis de notre époque. Ainsi, j'invite les chercheurs, les décideurs et aides professionnels de la santé à faire davantage preuve de solidarité, de générosité et d'ouverture pour la création de réseaux collaboratifs afin de produire du savoir qui contribue à accélérer l'atteinte des ODD. Aujourd'hui, l'Institut Pasteur continue de jouer un rôle crucial dans la recherche sur les maladies émergentes, le développement de solutions vaccinales adaptées à notre contexte, la formation de nouvelles générations de chercheurs africains, la coopération scientifique internationale, la surveillance épidémiologique. Pour terminer, je voudrais adresser un hommage appuyé à tous ceux qui ont contribué à écrire cette belle histoire, les chercheurs, les administrateurs, les collaborateurs et les gouvernements successifs. Le travail accompli par ces valeureux patriotes et acteurs de développement est une source d'inspiration et d'espoir pour les générations présentes et futures. Je voudrais aussi saisir cette opportunité pour remercier l'actuel administrateur de l'Institut Pasteur pour son engagement, son dévouement et son leadership qui a quand même donné un élan à cet institut. Je réitère l'engagement du ministère de la Santé et de l'Action sociale à soutenir toutes les initiatives qui contribuent à consolider les acquis de l'Institut Pasteur de Dakar et à l'accompagner dans son ambition d'être un pôle d'excellence mondiale, ancré dans la réalité africaine. Vive la science, vive l'Institut Pasteur, vive le Sénégal. Sur ces mots, je lance les activités du centenaire de l'Institut Pasteur. Je vous remercie de votre aimable attention. Maintenant, je reviens aux remarques pour seulement faire 2 recommandations à l'endroit de l'Institut Pasteur. Je sais que cet institut est en train d'écrire son histoire au Sénégal et en Afrique. Je voudrais bien qu'à l'issue de ce centenaire, qu'on puisse avoir un bon document de capitalisation pour que l'Institut ne parle pas seulement aux scientifiques, pour que l'Institut parle au public et que l'Institut parle aux Sénégalais. Ça veut dire en essayant de mettre tous les messages clés qui mettent en avant les réalisations de cet institut dans le domaine de la recherche biomédicale, mais l'impact aussi de cette recherche biomédicale sur les progrès accomplis en matière de santé dans notre pays et en Afrique, pour que ces éléments-là puissent être appropriés par tout Sénégalais et que quand il est à l'extérieur ou quelque part, qu'il puisse parler fièrement de l'Institut Pasteur avec les bonnes informations. La deuxième recommandation, c'est aussi de pouvoir, à l'issue de ce centenaire, expliquer clairement aux Sénégalais la place que l'Institut Pasteur peut jouer dans la mise en œuvre du nouveau référentiel des politiques publiques, notamment l'agenda national de transformation, surtout à son axe consacré au développement du capital humain et équité sociale. Comme ce référentiel coïncide avec le lancement des activités du centenaire. Et c'est aussi une manière de montrer la contribution de l'Institut à la transformation sanitaire et sociale de notre pays. Je vous remercie de votre attention. Merci.
Merci au docteur Ibrahim aussi, ministre de la Santé et de l'Action sociale. Mesdames et messieurs, nous voici à la fin de cette cérémonie riche en enseignements. Ce matin, comme je le disais à l'entame de ma prise de parole, nous avons célébré l'excellence. Nous avons mis en relief ces partenariats multilatéraux, ces collaborations entre experts du Nord et du Sud qui s'activent au quotidien pour préserver la santé et le bien-être des êtres humains. La jeunesse du continent africain constituant sa principale force, l'Institut Pasteur de Dakar a démontré son engagement continu envers l'éducation, la recherche scientifique de pointe et l'excellence académique. Et il en sera ainsi tout au long de cette semaine. L'héritage centenaire de l'Institut Pasteur de Dakar en matière de santé publique sera partagé autour d'une série d'événements destinés à célébrer les réalisations passées, à partager les innovations futures, les avancées actuelles plutôt, et à planifier les innovations futures dans le domaine de la santé publique. Merci à nos distinguées personnalités pour les discours prononcés ce matin. Merci encore une fois à toutes et à tous d'avoir assisté à cette cérémonie d'ouverture du centenaire de l'Institut Pasteur de Dakar. Heureux anniversaire à l'Institut, à qui l'on souhaite d'ores et déjà de très belles avancées pour les 100 prochaines années. Quant à moi, j'ai été ravie de vous présenter cette cérémonie et j'invite toute l'Assemblée à rejoindre la salle Évasion Marine juste à côté pour une pause rafraîchissement. Je vous remercie. Belle journée à tous.
Merci, c'est bon.
Test, test. OK.
De faire un peu de discours.
Bonjour, madame et monsieur. Est-ce que vous m'entendez bien? OK.
C'est comme ça.
Test, 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 test micro, test. Hein? Test micro. Pourquoi dans les photos? Test micro, test micro, microphone test. C'est bon?
Ako sorry. Jagal. Non, non, pas sinon je prends la test.
C'est bon? Test micro. Voilà. Test micro, test, test.
Hein? C'est ferme toujours.
Ouais, moi, je suis pas une référence. Ma voix est basse.
Ah, attends, bon. Et ces micro-tests, célébrons les 100 ans au service de la santé publique en Afrique. En Afrique. L'automatisation, c'est l'avenir, un centenaire d'excellence en santé publique. 1, 2, 3, 4, 5, 7, 7, 1, 2, 2. Microphone 2, essai du micro numéro 2, essai microphone test, essai du micro, célébrons les 100 ans, les 100 ans, les 100 ans, les 100 ans en santé publique. Tu es bon? Moi, Javier, c'est bon? OK. Batterie. Six cent quarante et un 600, moins 3, c'est bon? Oh, 7000, 655 700. OK, thank you. Six cent trente-trois 100. 633 100. Moom mi ngi nekk sax full énergie fu mu nekk nii moom. HF, les 100 ans, yokkal Institut Pasteur de Dakar, autonomiser l'avenir, un centenaire d'excellence en santé publique. Yes, sir. One, two, check up. C'est bon.
technology, advance detection and diagnostic technologies, develop effective treatment strategies, and promote public health policies for prevention. Without further ado, please help me welcome Dr. Xavier Berthet to the stage, who will give the symposium opening remarks. Dr. François-Xavier Berthet is an accomplished scientist and entrepreneur with over 25 years of experience in the life sciences, pharmaceutical, and biotechnological sectors. He has a proven track record in turning scientific innovation into marketable success stories with a particular focus on technology transfer, business development, and value creation across multiple industries. Currently, Dr. Berthet serves as the Director of Biomedical Research at the Institut Pasteur de Dakar, where he contributes to scientific excellence of the Research and Development Department. He manages the Grant Office and leads the establishment of the Center for African Resilience in Epidemics, Education and Innovation Center. He works at the intersection of bioinformatics, mathematics, and abstract algebra, which has led to pioneering research initiative. Dr. Berthet, the podium is yours.
Ladies and gentlemen, esteemed colleagues, friends, and honored guests. It is an immense pleasure, and it is with a lot of joy and gratitude that we are standing in front of you today. I say we because I am the representative of the 600 plus people working at the Pasteur Institute who have been striving to make this event possible and that will strive to make it a success. And I would like to acknowledge very dearly all the people who have been working to make this happen today. The centenary of the Institut Pasteur de Dakar is a momentous celebration. Over the last 100 years, the institution has been a beacon of excellence, a guardian of public health, and a cradle for discovery and innovation. We together are proud of that. And to paraphrase the words of Sir Isaac Newton's, IPD has probably been standing on the shoulder of giants to achieve what it has achieved. What we now expect is that for the next 100 years, those giants will not be sitting on our shoulders. We want new scientists to come up. We want new ideas to disrupt the status quo. We want new technology to change the game. And the purpose of this conference is really to fuel these new generation of scientists, these new ecosystem of people working together and contributing to make a difference in Africa and in the rest of the world. So today we gather under the theme from pathogens to countermeasures. We are reminded of the essence of our shared mission. Our journey with pathogen is as old as humanity. And over the past century, thanks to the tireless efforts of our people and all the scientists all over the world, healthcare workers, community leaders, community members, we have turned fear into knowledge. We have turned threats into opportunities. And we have turned outbreaks into moments of learning and progress. And we want to keep in this direction. The story of the Pasteur Institute is about transformation, but it is also about people. And it is built on the mind and the hand of women and men who dedicate themselves to curiosity, rigor, resilience. The researchers, technicians, clinicians, public health officials, and the many unsung heroes who work behind the scene, days and nights in laboratory, clinics, and field. They have contributed mainly to this result. So the path to pathogens and countermeasures is neither straight nor simple. It is full of detours, dead ends, and sometimes painful lessons. but it is also full of collaboration, solidarity, ingenuity, and discoveries. Each breakthrough becomes a milestone. Each pathogens remind us about the delicate balance between human health and the microbial world around us. As we embark on this conference, we will, during the next few days, have a very good roster of brilliant minds, excellent scientists, amazing people talking about the latest research on emerging pathogens, cutting-edge diagnostics, and innovative countermeasures. I am praying you to use and abuse of their presence to extract, connect, network, and establish connections, create value, and make friends. This is what we are aiming for and what we are wishing for you. I would like to finish by declaring this scientific event open, and I am proud of you, and I'm very happy to be with you today. Thank you.
Thank you very much, Dr. Berthet, for these remarks, setting up the stage for the next set of interventions from our speakers. I'd like to introduce our next speaker, Dr. Maria van Kerkhove. Dr. van Kerkhove is a distinguished leader in global health, currently serving as the acting director of the Department of Epidemic and Pandemic Prevention and Preparedness at the World Health Organization. In addition to her critical role as COVID-19 technical lead and emergency manager, Dr. van Kerkhove served as a global incident manager during the Mpox outbreak in 2024, which was declared a public health emergency of international concern. With over 2 decades of experience in infectious disease epidemiology, Dr. van Kerkhove has built a reputation for her ability to navigate complex, high-pressure global health crises. Her work spans a wide array of emerging infectious diseases, from COVID-19, Ebola, Zika, MERS, avian influenza, and Mpox. Dr. van Kerkhove's research primarily focuses on the interface between animal and human populations, investigating the transmission of zoonotic diseases, pathogens that spread from animals to humans. Please welcome Dr. van Kerkhove to the stage.
Good afternoon, everyone. Thank you so much for the opportunity to speak with you today. And I just wanted to pass my congratulations to Institut Pasteur de Dakar for this incredible accomplishment of 100 years, and wishing you and all of your collaborators 100, 200 more successful years. So in the next few minutes or so, I'd like to provide a little bit of an overview at a higher level of if the world is prepared for the next pandemic. I can end this presentation very quickly and say yes and no and take my seat again. But of course, we've all gone through so many different outbreaks, so many different epidemics. And unfortunately, it's not a matter of if, but when we will have this next pandemic. I often start my presentations with a number of questions, and I speak with many different types of individuals. I recognize the excellence, technical excellence in this room, but I have to ask the question of, do we remember? Have we forgotten? I think most of where I speak, no one wants to talk about COVID-19 anymore. And in fact, most people want to pretend it never happened. I know I'm speaking to the converted in this room, but if we're talking to politicians, if we're talking to the leaders of countries, many people think, well, we got through that. We need to move on to the next crisis. But if we look at back in December 2019, 5 years ago today, 5 years ago this month, there was a storm that was brewing, a storm that we had no idea would actually unfold the way it truly did. At WHO, we have systems that are in place, which we are constantly refining. We are constantly looking to evaluate and update and do better. When we first heard of this cluster of pneumonia of unknown etiology in Wuhan, China, within 24 hours, within hours, we set up our incident management team at the 3 levels of our organization in Manila, in Beijing, in headquarters. Within a couple of days after that, we used the information that we have to inform all of our member states and contact points around the world about what we knew, what was happening, what it meant, what you needed to do, and then alerted the world through our disease outbreak news. Within a few days after that, we issued our first package of technical guidance, and Institut Pasteur directly helped this because we quickly used our MERS guidance. Remember that other coronavirus, where we quickly adapted to what we were calling at the time a novel coronavirus. We've published the first PCR protocol together with Charité University, with Institut Pasteur, with US CDC, with Hong Kong, with Public Health England, as it was called at the time, where groups of researchers came together to look at what PCR protocol needed to be published. This allowed the world to start to develop PCR tests, and we at WHO were starting to ship those around in Africa and around the world at the end of January and early February. Our Director General, Dr. Tedros, issued a public health emergency of international concern on the 30th of January, alerting the world to really take steps to prevent the worst that would unfold. And then a few days after that, we issued a global strategic preparedness and response plan. But I have to remind everyone of the trauma that we did go through. And these are some of the images that haunt me every day, that remind me and remind all of us to inspire us to do better the next time. One of the ones here, I mean, you can see here the refrigerated trucks this was from New York City, that were temporary morgues. They're the fire pyres in India. They're the burial grounds in Brazil. But the image that haunts me the most is the one with the glove that you see there, where nurses in Brazil were filling up gloves with warm water to put in the hands of patients dying in ICU, so that those individuals didn't die alone. So we saw the worst unfold, but we also saw the best of humanity take place. And this is what propels us at WHO to continue to work with all of you to do better. But COVID-19 is not gone, of course. The desire to forget this pathogen is overwhelming, but it hasn't gone away. It continues to evolve. It continues to circulate without a predictable seasonal pattern. We have a virus that, although it's been circulating now in its 6th year with many unknowns, it continues to create burden on health systems, nowhere near what we saw in 2020, 2021, 2022. But still, some countries are estimating a burden of 2 to 4 times higher than that of flu. Some countries have had recovery, which has been quite strong, but it's been uneven. And many countries right now are dismantling the systems that were strengthened during COVID that are really important for the future. And so there's so much more that we want to do. While COVID catalyzed a lot of work on prevention, on preparedness, we see a lot of this being dismantled at the current time. But did we also remember these other outbreaks? Again, I know all of you in the room live and breathe these pathogens, so you haven't forgotten, but many else out there have. We've all gone through SARS, we've gone through avian influenza, we've gone through Zika, we've gone through dengue and Ebola. But what we have to do in the public health field that we work in to continue to communicate outside of the health sector to ensure that preparedness is a constant, that investment that we have is a constant, because those that experience these outbreaks actually did better during COVID, especially in the beginning. So the next question I often ask is, what are we doing differently? How do we use this example? This will not be the last emergency or pandemic that we will deal with. We have very poor estimates of the actual impact of COVID, some estimating around 20 million deaths, but that's actually for the first 2 years. We're working with member states right now to do excess mortality estimates to take into account 2022, 2023, maybe even 2024. We don't know the true death toll of this, not just from COVID, but from all of the individuals who's missed vaccines, who missed essential medical services and preventative services. It's had an estimated impact of $16 trillion. At one point, 1.6 billion students were out of school, many of whom have not gone back. A 30% reduction in investment in clean energy. And this last one of estimated more than 135 million more people pushed into poverty. These additional individuals who need humanitarian assistance as a result of climate disasters, of geopolitical crises, this is putting more people in vulnerable situations where these outbreaks are going to have an even deeper impact. This is a snapshot of global emergencies taken from last week. We at the organization are dealing with 41 graded emergencies at the same time. These involve infectious disease outbreaks, like you see with COVID-19, which is a protracted emergency. We have dengue in here, we have cholera in here, the Marburg outbreak in Rwanda, but we also have humanitarian crises and war, Ukraine, Lebanon, OPT, and we have humanitarian or climate-driven crises like floods and droughts. So all at the same time, our member states, our partners are dealing with multiple emergencies. And so it's a very crowded space. And it's a very crowded fiscal space and political space to have to deal with all of this at the same time. So what is really important is what we do every day and how our work collectively contributes to pandemic preparedness, prevention, readiness, and response. There's this false narrative that you either work in response or you work in preparedness. Well, of course, there's a spectrum. And we need to change this narrative that what we are doing is a constant, that pandemic preparedness is a constant. At WHO, our mandate on public health and security is in our Constitution, stating that the health of all peoples is fundamental to the attainment of peace and security and is dependent on the fullest cooperation of individuals and state. And this mandate is reiterated and expanded through our World Health Assembly, through these resolutions. During COVID, we went through many, many lessons learned exercises, many of which were done at the crisis of COVID, while we were working with member states to respond. And through these independent reviews, we synthesized more than 300 recommendations, and we developed this in consultation with our member states. We are the secretariat of 194 member states, coming up with a new framework which we call the HEPR framework, which is the Health Emergency Prevention, Preparedness, Response, and Resilience, which is looking at governance, systems, financing, with equity, inclusivity, and coherence at its core. Not just dealing with technical issues, but making sure that we look at all of the systems around this to make sure that this is sustainable, looking across the spectrum. So our member states are driving a stronger future. We've recently had IHR revisions, which is a massive improvement and a huge accomplishment of member states to update our international health regulations, which will come into force soon. We have looked at other instruments, and I'll come back to this because the member states right now are negotiating a pandemic accord, which we are all hopeful will finish by May next year. There's been significant investments at national investment plans looking at financing for sustainable preparedness. The Pandemic Fund is an example of this, which is now giving grants to many countries, focusing first on some technical areas of surveillance, of lab, and of workforce, and then the HEPR framework, which I've mentioned already. This HEPR framework is organized what we lovingly call the 5 C's of collaborative surveillance, of community protection, emergency coordination, safe and scalable care, and access to countermeasures. And the 6 core functions of WHO are listed on the right-hand side here, of providing leadership, of shaping the research agenda, of setting norms and standards, which is our bread and butter, and monitoring their implementation, to articulate ethical and evidence-based policy options for all member states, to provide technical support for high and low-income countries, for all countries of the world, and to monitor the health situation and assess trends. In our GPW, our General Program of Work of 2025-2028, GPW 14, we have these different pillars of promote, provide, protect. We sit under the protect pillar of preventing, mitigating, preparing risks to health from all hazards, to rapidly detect and sustain effective response to all health emergencies. But of course, we work across all of these other to provide health and to promote health as well. And I should say, I'm very grateful to be here with Dr. Chikwe and Sose and Rogerio and many others who are here. We are one WHO family, and I hope when you meet with all of us, you see that we represent a much larger number of people than you actually see at these meetings here. So I won't go into this, but normally what I do is I go through what will we do better, and this is the lessons learned part. I wonder how many lessons learned meetings each one of you in the room has sat through with SARS, with the 2009 flu pandemic, and are we actually learning these lessons? We know we have to act fast. We know experiences and preparation provide us with a much better opportunity to use the capacities we have better, knowing what is actually unfolding as we are learning about these pathogens that emerge. We know science is the foundation, and the stellar work of Institut Pasteur de Dakar across the entire Institut Pasteur family provides that. But science is only one essential element in terms of preparedness, readiness, and response, certainly in terms of developing policies. We know that even the best laid plans without trust, without leadership, will fail. And we saw that over and over during COVID. And there's always an election cycle. This year, there are 77 elections. There's always someone running for office. And these epidemics and pandemics outlive election cycles. And so the work that we do has to transcend these election cycles that we see. And pandemic preparedness is a constant. There is no peacetime. And so for us, we have to make sure that we are not contributing to this cycle of panic and neglect in the work that we do. So what we are looking at WHO is to provide a world that is better protected against all hazards affecting public health in order to reduce health, social, and economic impact of health emergencies. It's not just the health, it's also the social and the economic impacts, which was so clear during COVID. And we look at managing threats through different categories of pandemic threats and biosecurity, looking at high threat epidemics, looking at humanitarian crises and disasters, but also looking at these systemic threats and these unfinished agendas like polio. But we can't only look at these disease-specific threats. We have to look at the structural elements. And I mentioned this already of looking at governance, systems, financing. We have to look at the capacities that all countries need to be better prepared. These are the 5 C's that I mentioned in the HEPR framework. And the emergency cycle. If we do better at preventing and preparing, we'll have a much better opportunity to mitigate. We will not be able to prevent all spillover events, and we will not be able to prevent all pandemics, but we could do a much better job of mitigating the impacts of these pathogens with epidemic and pandemic potential when and where they emerge. And it's important that we engage society, we strengthen health systems, looking not only within the health system of primary health care, health security, health promotion, using a One Health approach, but looking across animal health and agriculture, looking at economics and financing, looking at social welfare and protection, disaster management and national security, and the environment in which we share. And making sure that we strengthen and we leverage our existing partnerships across the entire HEPR framework that we have here. Institut Pasteur plays a key role in this, not just within your laboratory systems and your diagnostic capacities, your contribution to WHO advisory committees, expert networks, but also making sure that the trainings that you do, that the contributions to science, the basic science of actually informing our evidence-based guidance really contributes across the whole spectrum. So we want strong subnational core capacities, leveraging partners and networks at national, regional, and global levels, and using the tools and technologies that exist and seeing what might be missing before we start creating new tools and new mechanisms. And this is all based and grounded in resilient communities. We often say outbreaks begin and end in communities, but communities themselves can prevent the outbreaks from happening in the first place. If we focus more on prevention, not just response, what might be circulating there and how can we equip our communities with information to prevent those initial infections and that transmission that might happen. So I give one example because this is my area of work within WHO with thousands of people around the world of looking at, are we actually taking concrete steps to prevent zoonotic emergence, spillover, and amplification, which, as you know, are not the same thing. So you've seen this statistic probably 1,000 times that it's estimated 70 to 80% of reemerging infectious pathogens are zoonotic. So how can we get better at detecting these pathogens in animals, looking at their epidemic and pandemic potential of infecting humans, their properties in which we would see human-to-human transmission, and mitigate that amplification? We have the One Health high-level panel that's trying to take this on, of looking at this not just from a technical point of view, but looking also at the incentives and disincentives for studying this, for transparency and reporting, and for making sure that we have better mitigation methods. But are we addressing the drivers of spillover? It involves much broader than the health sector. These are just some examples listed here. There's changes at the animal-human environment interface that is increasing spillover risk right now. Are we addressing climate change, which is increasing the risk for pathogens with epidemic and pandemic potential? We know that 4 billion people right now are at risk for chikungunya, Zika, yellow fever, and dengue, and that's going to increase to 5 billion within the next several years. We know this is not a theoretical. This is happening now, where vectors are moving further north, further south. There are countries that are seeing dengue transmission that have never experienced it before. We see Oropouche virus now. We see changes in animal husbandry practices, which is changing the risk of where these pathogens move. And it's driven by El Nino, La Nina. We have not addressed animal market practices and trade. This is something, if I put my money on where we would see the next pandemic, coming from our wildlife trade, of looking at how these animals are moving, the way in which they are sold, the way in which they are raised, looking at biosecurity, looking at, again, the incentives and disincentives for strong surveillance and activities in biosecurity in this space. We at WHO work with all of you to develop and learn from these experiences of developing strategies for prevention and control. And these are updated regularly because we learn constantly. Our bread and butter is around translating evidence into knowledge and action, using that data and turn that know-how into how-to. This is a constant piece of work that WHO with all of you do. The data that you generate in your labs, the data that you generate from your field studies directly is used in the development of evidence-based guidance. We work with patient groups, we work with community leaders and CSOs to make sure that what is developed is implementable and developed together with the people who these interventions will serve the most. We need to get better at anticipating risk for earlier detection. Capacities for diagnostic and sequencing have improved massively. I'm excited that you'll hear from Tulio next, and looking at just the example here in Institut Pasteur in Senegal. At the beginning of COVID, as Chikwe said, there were 2 countries in Africa that could do detection of SARS-CoV-2, Senegal and South Africa. By the end of April, 94% of member states across the African region could detect SARS-CoV-2. That was better than many high-income countries at the time. But what we want to do, this is a graph, it's a static image from some mapping that we've done looking at spillover of pathogens with epidemic and pandemic potential. There's 18 pathogens included in this. This is an interactive map that we have. These are the pathogens that are included, driven by a huge amount of research from people around the world, working with FAO, working with WOHA, working with many academic groups. And these are the pathogens we've chosen to start with because this is where we have data. We can group them by transmission or vector. We can look at different layers of diagnostic capacities, healthcare system services, and reporting capacities. And our goal really is an advocacy piece with politicians, with leaders to say, have you considered the pathogens that are circulating? What about these other ones? We hope to update these every 6 months or so. It'll probably be once a year, taking into consideration the changing landscape in which we live, looking at the different environmental factors, because we want to strengthen and sustain preparedness, readiness, and response capacities to limit the spillover and amplification in human populations. We're also looking to manage threats more effectively. So Amadou, you were part of the work that we did and are doing on the Global Arbovirus Initiative, where we're looking at multiple pathogens. First, we're considering chikungunya, Zika, dengue, and yellow fever, but we hope to add more arboviruses to this because this is the same people in country who are working on these types of pathogens. We also need to manage our respiratory threats differently. Right now, what we see in many countries is this notion that COVID is over, so we're going back to flu. And I'm overgeneralizing here, but if we're going to be dealing with respiratory pathogens and patients that are showing up at healthcare, we need to test for the spectrum of respiratory viruses or respiratory pathogens because bacteria will be included in here as well. And leveraging the capacities that we have and increasing those for the current and future threats that we face. I won't talk about avian influenza, but we are massively concerned about this epizootic of avian influenza that's happening. A lot of attention happening in the US, but we are very concerned about new species being infected, about the potential reassortant capabilities, and we all lived through the 2009 flu pandemic. This is just illustrating that. This is looking specifically at 2344B viruses, which has massively expanded since 2020. As we were dealing with COVID-19, we have new species infected, but we do have the Global Influenza Surveillance and Response System that is monitoring and assessing these pathogens. We have many WHO collaborating centers and national institutes who are contributing to the risk assessments that are taking place of the animal viruses and the human viruses. But we're only as good as our ability to analyze of what is contributed within this system. But how many of these outbreaks could be prevented? If we look at this, Mpox. I didn't spend any time talking about Mpox here, but we are in the second public health emergency of international concern since 2022. And there's a lot that's happening in terms of looking at the spread and actually looking at the zoonotic spillover, the human-to-human transmission that's happening. A lot of attention in DRC, but we want to make sure we also look at the neighboring countries so some of those initial seedings don't turn into massive outbreaks in the countries. We've had the Marburg outbreak in Rwanda, and we haven't had a case in I don't know how many days. I think we're coming up to the 42 days without a case. There's a terrible cholera situation that's happening globally, completely preventable. On the bottom is just looking at Pucha, Zika, Chikungunya, and Dengue in Paho region. So this is a constant that we have to manage our time to deal with all of these different types of threats. So one of the things we want to see is leveraging the gains that were made. Laboratory capacities expanded massively during COVID. And this had started before COVID, of course. Globally, at one point, 84% of member states had the capacity to sequence SARS-CoV-2. And again, I'm glad this session is going to be talking about this. Sequencing for SARS-CoV-2 doesn't necessarily mean you can sequence for other pathogens, but those capacities that exist in countries, we want to see stay in countries. No longer are we in a situation where samples have to be shipped to high-income countries to do the work that can now be done in countries in the region using local knowledge and brain power to use that information to drive actions. I could give you other examples of oxygen scale-up, of using clinical care, of infection prevention and control, of the use of emergency operation centers. But this is what we want to see maintained, not at the level that it was during the peak of COVID, but certainly to be right-sized within countries to deal with what are the known and the potential future threats within the borders and what crosses borders, because of course, these pathogens don't cross borders. We also, at WHO, I think, as one of our superpowers is harnessing the world's global expertise, which is sitting in this room, of working with all of us across the HEPR framework. This is a brochure. It's actually a document that catalogs all of the advisory groups, the WHO CCs that we have across health emergency preparedness, prevention, readiness, and response. And I just gave a couple of examples that are here that are under, some of which are under my responsibility at WHO. But this harnessing of expertise is also changing. We are diversifying the groups and the people who are part of these advisory groups, bringing in mid-level career staff, bringing in junior voices, bringing in youth to be able to kind of kick the tires, if you will, of the establishment and looking at this, taking a new approach, because we are not the same organization. We are not the same world that we were 5 years ago. I just quickly mentioned biorisk because we also need to manage not only the zoonotic spillover, but we need to anticipate, prevent, mitigate, and manage biorisks across the entire spectrum of dual-use research. And this is handled by our science division. But the emergencies program is also looking at the capacities development and looking at laboratory biosafety, biosecurity, our preparedness to detect, assess, and respond to deliberate release, to look at our readiness for deliberate events and looking at the health security interface. These technical aspects are massively challenged now with misinformation, disinformation, and AI. Imagine what these next outbreaks will bring with AI. And imagine, you don't have to imagine very hard, the threat to economies, the threat to stability of looking at doctored videos of what might unfold. It's bad enough from a technical point of view, but with AI, this could get a lot worse, especially in the context of reduced trust. We do have a new resolution, and it's an updated resolution looking at strengthening laboratory biological risk management. This was just approved at the last WHA, calling on member states to promote a risk-based approach and safety culture. And this is important because of this expanded laboratory capacity around the world. I'm almost finished. Just mentioning two important aspects. This exists already. This is the Pandemic Influenza Preparedness Framework. This was established in 2011, adopted by all member states. This exists now that we use for influenza. We're utilizing this right now in an interpandemic period for avian influenza and H5N1. We have to make sure that the inequities that we witnessed during COVID doesn't happen again, but this has to be beyond a handshake. It has to be actually in a legally binding agreement. And this exists for influenza, but we don't have an agreement for other pathogens with epidemic and pandemic potential. What we do have right now as a placeholder is this interim measure looking at the equitable access of medical countermeasures. So our IMCM net, which is working with many, many different partners, is making sure that we have global coordination to improve equity in the development, manufacturing, and supply chains and distribution of medical countermeasures for pandemic threats. We're utilizing this for MPOX right now, where we set up an access and allocation mechanism. We have a biohub system where samples are shared between laboratories to be able to do characterization and do further studies to understand the risks that these pathogens pose. And we're utilizing this right now for H5N1 and for MPOX. And this is a placeholder. We have the IHR amendments, which I've mentioned already. This is a picture from when they actually agreed. Everyone was thrilled. And I've mentioned this already, but this will come into force, I think, next year. It's still being discussed by the member states of how this will happen, but this was agreed at the 77th World Health Assembly in June last year. And right now, they are continuing this intergovernmental negotiating body, the INB, is discussing this pandemic accord. So we're coming up to the final stop, the goal of WHA 78, where we're looking at in May, hoping to have this agreement agreed by member states, to have this binding agreement. And we can say that, that they were just in WHO again last week. They've met numerous times, and there's much more agreed than there's disagreement. We are very optimistic. We have to be optimistic that they will agree to this by May, because again, the member states that are sitting in that room that are negotiating in good faith. They're not sitting in that room to see it fail, but it is complicated. But there are very thoughtful discussions that are taking place. And this is one of the things that we will see here across the prevention, preparedness, readiness landscape is this PABS-based system of sharing access and benefits for pathogens with epidemic and pandemic potential. So still lots to negotiate, but we are quite hopeful that this will be agreed by May. And our ultimate goal is to have a world that is alert and ready to respond to emerging threats. This doesn't mean the general public. This doesn't mean everybody needs to be thinking about this all the time, but we do. And we need to collectively contribute to preventing animal to human spillover, to increasing preparedness capacity and operational readiness, to rapidly detect and notify, respond to new events, and to develop and ensure equitable access to countermeasures. And it's all based on these 4 words in red at the bottom, on science, on trust, on transparency, and on collaboration. And we see this across the Institut Pasteur and Institut Pasteur de Dakar and across the entire network. So thank you very much for what you do. Thank you for your contributions to science and to public health. Keep working hard, keep collaborating with us, and we will rely on you to help us shape a better future. Thank you.
Thank you very much, Dr. Van Kerkhoff, for this brilliant talk. Thank you for reminding us that there are many lessons learned from the COVID-19 pandemic and other pandemics, and for sharing how WHO is leveraging these lessons learned and capitalizing on existing capacities to better prepare us for future pandemics, looking at the issues from a whole of society approach, health systems, and holistic approach. I'm now delighted to present our next speaker, who is joining us online. So I hope Professor Tulio de Oliveira is here with us. Professor de Oliveira is a bioinformatics and genomics expert specializing in infectious disease epidemiology. He is the founding director of the Center for Epidemic Response and Innovation, based in South Africa, which focuses on genomic surveillance to track and control emerging pathogens. Dr. de Oliveira played a pivotal role in identifying and monitoring SARS-CoV-2 variants, including Beta and Omicron, during the COVID-19 pandemic. His work bridges advanced genomics, public health, and policymaking, particularly in Africa. He collaborates extensively with global health organizations to enhance epidemic preparedness, and he has received international recognition for his contributions to science and public health. Welcome, Dr. Oliveira. The floor is yours.
Yeah, thank you very much. Yeah. And I hope you can hear me well. Yeah. And first, congratulations to Professor Amadou Sal, to Javier for this 100-year celebration, yeah, which we were extremely proud. And I think that's going to be very clear during my 15 minutes presentation, how proud we are of the IPD and how close we work together to really make Africa and the world as a safer place. Yeah. So just to start my presentation, the title is Respond to Epidemics as They Arise or Before They Arise. Yeah. And fantastic to follow Dr. Van Kokova because she gave a big introduction. Yeah. So I just have to explain how we do that. Yeah. But before, just to say, what's the vision? The vision is to respond effectively to epidemics through pathogen genomic surveillance, this being the bedrock to really enhance biomedical discovery, to design treatment, diagnostics, vaccines, to be able to prevent and control many diseases in Africa and the global south. So that's our big vision, and that's what we work together. As it highlights, a lot of this work, it started during the COVID, at least putting big networks together. And here it is what we put together in South Africa. The Network for Genomic Surveillance South Africa was the second global network of genomics to come as a country, came a week after the UK one, where we managed to get like 9 genomics labs to work hands in hands to respond to the epidemics as they arrive. That was fully funded by our government, the Department of Science Innovation and South African Medical Research Council, really highlighting the importance of national governments to start funding research and response, and together between academics, institutes, and the NICD. Once we discovered the first variant, the beta variant, we grew a much bigger consortium where we led like over 500 scientists with very direct contact to the Department of Health, with the minister and the presidency, where we put together genomics, virology, immunology, clinical trials, and epidemiological modeling to really respond in real time. We end up doing some of great science, but also discovering the other variant, Omicron, but quite important, then working with the WHO and the Africa CDC to win a big global competition to set the first mRNA hub in Africa, in a process that we can produce our own vaccines in the continent, which of course the IPD is one of the highly developed centers on that kind of network. Yeah. So even despite during the pandemics, we thought that all this infrastructure should be coordinated and to deliver to the whole continent. So SERI and CRISP, the 2 institutes that I direct, it is a specialized genomics facility of the Africa CDC and the WHO Afro. So it fit in a greater network where the Institut Pasteur de Dakar and the Nigeria CDC or the UVRI, Uganda, or the NICD are regional facilities, which our mandate together is to help every single member state. So during the pandemic, we sequenced for 24 countries in Africa, but to also provide training to all member states. And that's what we did. We did together, but we did that in a holistic process, that the idea is not to do the same as the Global North have done in Africa for hundreds of years, but to completely work together to share all the protocols, all the data sets, all the analysis, all the training. And we end up putting together these massive programs in Africa. The first one that analyzed all the data together, we had 148 collaborators from Africa and led from Africa. The second one, 342 collaborators, yeah, which then built in a very large training program. So we thought that our main mandate together, for example, with the Institut Pasteur de Dakar, is to support other countries, and we invest on that. In Syria alone, we received 608 fellows from 50 African countries that come from short-term, middle-term, and long-term fellowships that they stay months or years receiving and taking the process back to the country. I am happy to announce that as part of the 100-year celebration, our large international workshop that is in the 29th edition next year is going to be run with the IPD Dakar. So more and more, you're going to realize how we can work together to really capacitate the whole continent. And what we do with what we call this army of fellows that have been trained is that if they see a new outbreak in any of the countries, we will support them with sending protocols or reagents and guiding on the response so sequence can be done in real time. We have dozens of examples of that, of working together, for example, with Dr. Musa and Idrissa at the IPD to characterize new strains of chikungunya or dengue, or identifying big outbreaks across the continent. And what we do is to create this system that Africa can respond to their own epidemics. So let's give you just two quick examples. One of them, it is to try to produce vaccines in the continent, mRNA vaccines for pathogens that have been neglected to Africa. And what we did with the Afrigen and the Medical Research Council and the WHO mRNA Hub is to go and identify and characterize all the genomic surveillance of Rift Valley fever. So we did that as a collaboration, that we identify, create a new classification system in the same way that we did for Mpox or the variants that we created with the WHO to COVID, to identify all the main strains that circulate in Africa, and then to feed these genomes to vaccine design. And what I'm happy to say is in the last couple of months, we have the first mRNA constructs for Rift Valley being produced by Afrigen in South Africa in collaboration with us, just showing that development of vaccine end-to-end is possible in Africa. At the moment, we are working on the pathogens such as West Nile virus. And then as new epidemics emerge, we respond also very quick. So that's the great work that we did together with collaborators at NRB in Kinshasa on characterizing in real time and very rapidly the new strain of Mpox on the DRC. With the WHO, we change the name of the disease from monkeypox and a highly discriminative way to a more neutral one. And then with the international community to generate a new classification system that allowed to track the epidemic. And that allowed very recently, working with the DRC, to the identification of a new clade 1B, that we did with teams in the INRB, that really identified the new clades, identified new mutations associated with human adaptations. But more important, that this identification that allow to call again the emergence and make available finally vaccines to Africa. We have been basically neglected during the Mpox, and just a new strain allow transmission human to human to finally wake up and get access to vaccines and countermeasures. Just to see how genomics can sometimes be a font of identification for action. And then just to finalize this program that we do, we think that all this expertise that we generate in Africa should be collaborated with other countries in the global south, with Fiocruz and the PAHO and many collaborators in Latin America. Very similar as we have done in Africa, we have trained hundreds of scientists and now supporting them to trace and to respond to the main outbreaks. What we have seen in Latin America and parts of what country Africa is the biggest ever outbreak of dengue, but also the emergence of a new pathogen, Oropochi, which was characterized in real time together with the national labs and the Fiocruz in Brazil. And that's a pathogen that used to live in the Amazon forest, the Amazon basin, and to increase the population density, but forest loss through agriculture. It put animals in closer contacts with humans, and the pathogen adapted as a reassortment, similar recombination event, and start causing large outbreaks, leaving the Amazon basin and starting transmitting multiple stages in Brazil, but now in Colombia, in Cuba, and being introduced around the world. But the work that the identification of pathogen very quick and very fast, the Brazilian government respond to control that. Other one that Dr. Van Kokova highlighted that we can see happening again a lot is the reemergence of cholera. We had this worst outbreaks in Africa, which we helped to characterize in Cameroon, Mozambique, and Malawi, but also the reemergence of cholera in Haiti, in a situation really there. The situation in Haiti is absolutely catastrophic, with massive gangs and completely destruction of a health system. And that following after extreme climate events, a new outbreak of cholera that spread around the capital. And to our surprise, we thought that this new outbreak, which was named Latin American strain number 3 or LAT3, was not an introduction from outside, similar as it caused the previous one, but a reemergence of a strain of cholera that leave the environment, circulating in the environment with an extreme climate event and also destruction of water distribution mechanism, and go to cause a very large outbreak, especially in young children. Just highlighting the association between climate change, destruction of the environment in Oropochi, in cholera, to cause that. Just to finalize, my last slide is that, sorry, I'm not going to get too much in the mathematics of that, but it is that one thing that we're going to do, it is starting to identify pathogens before they emerge, So with the Brazilian Navy and the Ministry of Health of Brazil, we put a large program together in these Navy boats that go with a team of medical doctors to very difficult to reach populations. And in that process, to try to identify very quick new pathogens before they leave the forest areas and start transmitting. So what we have to do is to have a really good genome libraries, so vaccines and diagnostics can be produced in real time, such as we can achieve the 100-day mission. So to conclude, we have intense activities in Africa and Latin America. The idea of working together in the climate or SERI or different consortiums is a holistic consortium that involves not only receiving samples on the opposite, but involve large training, capacity building, quick responding, genomic surveillance, and public health guidance, and really getting these tools in the hands of everyone that have been trained in the different countries. We start with a wide engagement with Asian partners. We think that's very important that many countries that suffer these epidemics working together. And now we have an army of well-trained people that need to elevate them to the next level. And then to finish, just to share the great news that together with the Institut Pasteur de Dakar, we are launching early next year the African Staff Fellowships, which is a fellowship program that to bridge the gap of Francophone and Anglophone countries in Africa, with going not only from genomics, but with advanced and translational training. Let's get these tools in the process that young people can develop that to create programs, to create countermeasure. We are also launched together Master of Business Administration and Health Leadership to really grow the next star of scientists in Africa, and together with the Institut Pasteur de Dakar. Thank you very much. Just to think quick about the funders, and it's sorry that I'm not there in person, but I'm there in by heart, as together in this celebration. Thank you.
Thank you very much, Dr. Oliveira, for this tour de force in how you've leveraged genomics, generating an army of African fellows to really strengthen genomic surveillance on the continent, using genomics to develop new countermeasures, vaccines, and diagnostics to better prepare our health systems to the next pandemics. We will now move to our next session, which is a panel of experts here at IPD. I would like to first introduce our moderator, Dr. Marie-Henriette Dionnet. Dr. Marie-Henriette Dior is a research scientist in the virology department of Institut Pasteur de Dakar. Her field of interest is the study of interactions of viruses with their vectors and hosts, and the rapid detection and assessment of the immunological implication of emerging pathogens. Welcome, Doctor. I'll next invite our panelists, starting with Dr. Ines Vigan-Womas. Dr. Ines Vigan-Womas is a research director at the Institut Pasteur of Dakar, specializing in infectious diseases with a focus on sub-Saharan Africa. With over 2 decades of expertise in cellular biology and immunology, her research addresses major diseases such as malaria, cysticercosis, leptospirosis, plague, dengue, and more recently, COVID-19, which have had significant public health impact on the continent. Her work has been crucial in isolating Senegalese monoclonal antibodies against SARS-CoV-2, Crimean Congo hemorrhagic fever, and Rift Valley fever, which hold potential for vaccine development and diagnostics. Next, I'd like to invite Dr. Moussa Moïse Diagne. Dr. Moussa Moïse Diagne is a research scientist in the virology department at Pasteur Dakar and is dedicated to advancing pathogen discovery and response within the One Health framework. Utilizing next-generation sequencing methodologies, his work bridges epidemiology, genomics, and public health. He has played a crucial role in epidemic responses, contributing to the containment of 2 Ebola outbreaks in the Democratic Republic of Congo between 2010 and 2019, and the Marburg outbreak in Equatorial Guinea in 2023. Dr. Diagne serves as the head of IPD's sequencing platform and is a deputy head of the WHO Yellow Fever Regional Reference Laboratory. Welcome, Doctor. I'd like to invite next to the stage Dr. Mariam Diarra. Dr. Mariam Diarra is a biostatistician and researcher at IPD, specializing in applied epidemiological modeling of infectious diseases. Her work focuses on the development of mathematical models of epidemics for prevention and evaluation of the impact of intervention strategies, such as the impact of vaccination. During COVID-19, Dr. Diarra has conducted research to understand the dynamics of SARS-CoV-2 transmission and to evaluate optimal vaccination strategies against COVID-19 in Senegal using mathematical modeling techniques. Welcome, Doctor. And lastly, I'd like to invite Monsieur Andy Diouf, if he's here. Andy Diouf. Mr. Andy Diouf is a researcher in the virology department at Institut Pasteur. His work focuses on the surveillance of dengue viruses. He utilizes next-generation sequencing technologies, including Illumina and Nanopore, to conduct genomic surveillance of circulating variants in Senegal. This initiative is integrated into the Senegalese Syndromic Sentinel Surveillance Program, the FOREST network. He supports the effective monitoring of genetic composition of dengue and evaluates its implication for preventive, therapeutic, and diagnostic investigations. Thank you to this panel. Dr. Dionnet, the floor is yours.
Alors, nous allons passer au panel Nos différents panélistes vont nous faire des présentations sur le thème « Décoder les pathogènes, perspectives sur l'immunologie, la génomique et l'évolution ». Nous avons commencé par une première présentation avec Dr Inès, qui est spécialiste en immunologie. Docteur, la parole est à vous. Merci.
Good morning, everyone, and thank you. And it is a great pleasure to do this panel with all my colleagues today. So if I can have the presentation, please.
Is okay. Tell you something goes. Okay. Dans la présentation.
D'accord. So just first of all is we are at Institut Pasteur de Dakar, and we have a big legacy of Institut Pasteur for immunology, and I think that Louis Pasteur is for me the father of immunology. He has a great careers, and during the scientific careers, the main things that he brings for the world is first the discovery of the microorganisms that can cause diseases. And after that, he discovered also the way to do food and beverage safety by pasteurization and sterilization. And after that, the big legacy of Louis Pasteur is the first that bring this vaccine, and vaccine with several diseases, anthrax, rabies, cholera, tuberculosis, and smallpox. And this conception that we can treat and really treat the patient by vaccine against microbial diseases, but also provides a way to develop this vaccine and this attenuated vaccine, and also how to manage and this notion of large-scale vaccination of the population. And by doing that, he brings the fact that the immunity and immune responses are the first response that for the host against diseases, and this vaccine raise this immunology. So for Nobel Prize, we have many Nobel Prizes that were awarded around the world, and 27 were Nobel Prize for immunology. And I don't want to go through here, but this immunologist and this disciple of Pasteur shown that and decipher this immune system by discover the serum therapies, the discovery of mycobacterium, tuberculosis, and also the vaccine against these diseases, discovery of phagocytosis, and one of the discovery also that was awarded by the Nobel Prize is the discovery of the stable a yellow fever vaccine that is used now to manufacture vaccine. And the last one, but not the least, is was awarded to Kathleen Carrico and Drew Weissman for the discovery of mRNA vaccines that land the COVID-19 vaccine development. So the immune system is very complex, and this immune system generally is presented very simply by the combination of innate immune system and the humoral and adaptive immune system. So this system is developing since the beginning of life and is impacted by mother immunities, age, sex, nutrition, environment, genetic of the patient, microbiome, and ethnicity. And this immune system is also in all the bodies and is in tissues, and we have developed during the last centuries many tools to investigate these immune systems. So when we develop tools and when the pathogen encounters this immune system, the pathogen is also very, very agile to develop this immune escape, as we can see during the COVID-19 with the emergence of several variants, also induce immune dysregulation and can also infect immune cells to escape to this immunity. And our work is really to characterize at the beginning the immune system and to drive this correlate of protection that can drive also the vaccine and the treatment development in the patient. So this immunity is a question of volume, not too high, because if it is too high, you raise severities and damage of the cells, but not too low, because if it is too low, it is a pathogen who gains the game. And this is this kind of regulation that the immune system has to have the activities and after to have this just these activities around the pathogen and to go down to homeostasis. But by going down by homeostasis, the immune system becomes resilient because the memory arrives, and when you encounter the next time the system, you are more resilient to the diseases. So when we face a pandemic that we have facing during COVID-19, our main goals is first to decipher this immune response by several tools, this humoral and cellular immune response, and to define by the beginning the tools to evaluate these immunity levels and develop diagnostic, but also to do an effective at least surveillance of the diseases and focusing always on translating science and evidence-based research into public health tools and strategies. So I will just talk about what we have done, some focus of what we have done during the COVID-19 period at Institut Pasteur de Dakar. So as you know, COVID-19 cases reported by WHO shows that Africa was the continent less impacted by these viruses. But why? And it is a question that we have to resolve to become more resilient. First of all, of course, we have underreporting and limited testing during this COVID-19 period, and this map shows that Africa is developing less testing during this period, but also we have demographic factors that can explain this less impact in Africa, climate and environmental factors, genetical factors, but also maybe low transmission. But how to measure this transmission and how to prove that we have low transmission during this period? And we work a lot with WHO and all the partners, first to define the best tools to focus on this transmission and show if you have less or more transmission. And what raised for the first time is that even if the diagnostic tools were developed in Europe and USA and give high performance in terms of sensitivity and specificity, when they arrived in Africa, we have less performance. And these results show that here in Africa, the level of the basal immunities against the SARS-CoV-2 protein at the beginning are very high. So we have to manage and to bring on the board the best diagnostic tools to countermeasure these cross-reactivities and these antibodies against SARS-CoV-2 that was seen in malaria infected population, but also in population infected with other diseases like arboviruses. So we work a lot with WHO and all our partners here to have these good tools in hand. And after that, when we have these good tools in hand, it is the moment to investigate what is the real transmission of the virus in our population, and two serological surveys were performed here in Senegal, and the results shown that from the first seroprevalence surveys done in 2020, the circulation is already there, because we have around 14% of the population that have already encountered the virus, but this is very heterogeneous between the region. And in 2021, after the Delta virus, we see that we have the herd immunity is already in our population, showing indeed that we have a high transmission, and this low impact of COVID-19 in our population was not due to this low transmission. So we have always also done studies by investigated the epitope mapping, the major epitopes that are targeted by the immune system. And we have used more than 400 peptides to do these studies in Senegal and in Madagascar, leveraging the strength of the Pasteur network. So what this study has shown is that the peptides that we have discovered, the 36 peptides that we have discovered and pointed out, are similar between the two countries. They are also similar between Asia and Europe. So, and distributed mainly in the spike and the nucleocapsid proteins. But they are located, as you can see here in the yellow, outside the RBD who binds and involved in the entry of the virus in the cells. They are situated and located outside these spaces. So indeed, it is very useful for us because he will guide vaccine development. But what we have seen in this period all around the world is this plane coming from a war with a lot of impact. And we want to see what is behind this lot of impact. And it is now for us to gain into knowledge to predict with all the serological and immunological tools and the results that we have, the possible mutation points of the pathogen using AI in silico modeling and genomic algebra to target the point where the parasite is very fragile. And it is our main goals now. And the Omicron variant show indeed that when the Omicron main mutation was done by the virus, indeed this mutation opened a little bit the protein and allow to the immune response to tackle this virus. So now we are working a lot on building a pandemic intelligence system by bringing with us, and because we cannot do this study alone, we have to rely on our surveillance system around Senegal, but also in the border countries. To pathogen genomic and sequencing, and Moussa Moïse will come back soon with this description, with epidemiological and clinical studies that will allow us with our partner in local, with the hospital in local, to have this very useful and very helpful biobank of serum, plasma, PBMCs to decipher this immune response using several tools, and these tools are immunological tools to better define the antigens and the monoclonal antibodies to be developed against all the diseases that we are facing, including disease X, and bringing this research results to our new vaccine manufacturing with Madiba, but also Jatropics for the diagnostic tool and Davax. And it is where we are going on with all this program and building a flexibility, inclusion, and a resistance system, including immunology in the heart of pathology to prepare the next pandemic. Thank you so much for your attention.
Thank you, Dr. Ines, for this nice talk, which allow to understand the better implication of immunological stance in SARS-CoV-2 virus, which caused a pandemic in around the world. We will move on another presentation with Dr. Moussa Moïse Diagne. Moussa Moïse Diagne is specialized in virology and genomics.
Thank you, Oyet. So, good morning, everyone. So I have a double stress because the first time, it's always complicated to go after Ines first. And the second, the last time I was in this position, it was during my PhD defense. And I was in front of Amadou Sall. It was really complicated. So it went well at that time. Fingers crossed for this one. And be kind. Thank you. So I will go, and I'm really happy to have this type of opportunity to share some insight on pathogen genomics and discovery. This is a field of interest because it's really a key point to reshape global health. And it's also a point where we have multidisciplinary approaches that can go together to make our public health solution more impactful. So, as we are celebrated this centenary in IPD, there is a question: how can genomics continue to reshape pathogen discovery and global health? So, how we can go beyond what we already done? So, this needs to be the opportunity to bring innovations in terms of genomics, but also in terms of structural biology or diagnostics. So, what is pathogen genomics? Pathogen genomics involves the sequencing and analysis of genomic materials of infectious organisms. And why is it important? First, because it allows to discover new pathogens, of course. It also tracks their evolution. And also, it helps to guide interventions like vaccines or diagnostics that will be tailored in a dedicated situation. And in IPD, our journey in genomics started in 2010, more or less, and we built a capacity to have now the ability to sequence up to 5,000 viral genomes per week, more or less, with a huge HPC, placing us as a cutting-edge platform in Africa. So I will want move to on the COVID-19 pandemic. It was well covered by Ines, but we have been a key player in this genomic surveillance in both Senegal and Africa. So we covered about 75% of the genomes. So we gave 75% of genomic information from Senegal here in IPD. And we are also a key player in data management since we are also a GZ hub for West Africa region. And at a regional level, it was also mentioned by Tulio, we have covered 18 countries, mostly in West Africa, but also in other regions, to give really vital data for tracking viruses and guide public health decision makers. So let's dive into like specific case studies. And I don't know if people are from Kedugu, but this is one of my favorite place because my PhD thesis was in Kedugu, and I did a lot of work here. There is a big opportunity to work there. It's a nice place too. But also we have a lot of outbreaks. So let's go with this one. Yellow fever outbreaks that occurred in 2020, late 2020, early 2021. So after detection with colleagues of several cases, we have been able to sequence the virus in both humans and mosquitoes. And what was interesting, if you look at, I don't know if you can see, nope. Okay, there is an alignment of a sequence, but when we are able to see a specific mutation, 6 nucleotide deletion in a specific region where which is what was never seen before. So this 6 nucleotide deletion was at the flaviviral subgenomic region, and it means that this region could be affected in terms of fitness by the pathogenicity, by the adaptation to host, but also by the transmissibility of the viruses. And so, thanks to genomics, we have been able to identify interesting patterns that need to be studied in vivo. So the study is ongoing and to see what role do these mutations have in the evolution of yellow fever. And what is very important, this trend is currently circulating in Senegal. It was recently identified again this year. You can see in the street with red labels where we have been again identified in mosquitoes and humans. So it means that there is a beginning of endemicity of this new type of yellow fever, and this is an interesting point that needs to be explored. So we have also a chikungunya outbreak in eastern Senegal again. In 2023, it was mainly observed in gold mining sites. And what we did is a real-time surveillance, genomic surveillance. And by doing that, we have been able to identify the evolution of this virus, but identify the emergence of new mutations, mainly 2 amino acid changes that are able to impact replication, antigenicity, and host adaptation, meaning that this new, this virus that occurred in Kedugu and Tambacounda could be of interest in terms of vaccine development. Another work done was not in Kedugu only, but in the Senegal with a molecular evaluation of dengue, where through a regular genomic surveillance, some diagnostic erosion was identified in some strains. So meaning that some strains are not identified by the current the diagnostic assays that are used in routine. So there is a need to strengthen the genomic surveillance to identify what are the cause of this diagnostic erosion. But even more important, we have this approach where dengue vaccine may not be effective for all circulating dengue in Senegal. So it was shown by a study done with Idrissa Dieng, where it showed that this dengue vaxia and tetravax could not be as effective as it should be for dengue virus 3 serotype. So this is some few examples on how genomics can be critical in terms of public health interventions. Another example, but not on human, it's how metagenomics can be used for veterinary, for instance, not only human. So we merge 2 approaches, metagenomics and xenosurveillance. And xenosurveillance is the way to use mosquitoes' eyes like a living syringe. So we use those mosquitoes. We use their blood we perform a metagenomic screening and to identify all the different pathogens that was in their blood. And we identified a lot of viruses, as you can see here. But in red, we see this virus named Jaxete chip retrovirus, which is one a retrovirus which is 100% lethal to ruminant. And the first evidence of this virus in Senegal, and it's the detection of this virus is quite sparse because there is no like gold standards in terms of molecular or serological assays. This one is a way to see how metagenomic can be used for also identification, even for pathogens of veterinary interest. So, besides the traditional genomics approach, we have also some other approach like the biomarker-based one. So when you talk about viral pathogen discovery, we are talking about this one self all analytical metagenomic framework, which is really adaptable, where all type of samples can be used to do a kind of metagenomic workflow to detect any type of pathogens with no specific pipeline. But what is the limit of this approach is the scarcity of viromic patients. In reality, it's really complicated to find acute viromic patients. In this plot, you see that the red one are the viromic one, while all the rest of the people are maybe positive by immunological assays and etc. So it's really too late to identify them by genomic approaches. It's like try to find a needle in a haystack. So we need a robust and comprehensive sampling algorithm to enhance viral discovery efforts. And that's why this type of biomarker-based approach, where we mixed some specific biomarker for interest, like that can be of interest, like the MXA for myxovirus resistant protein A, which is mainly focused on viral infections, plus the metagenomic is really critical to allow the diagnostic of viral infections. And we did that. So we had now in our end a MXA RDT that is used like a malaria RDT. So it's now implemented in Kedugu. We have several health sites where those guys the healthcare workers are using this MXA RDT. So we have two sites where we use that, and we have been able to see that we have a great correlation between the MXL levels and the positivity for any type of viruses, as shown in this plot, where we have been able to identify, to distinguish chikungunya infected people to dengue to negative one, thanks to this RDT and the metagenomics. So we see that we may have to do to combine different approaches, NJS plus other type of approaches to get a better resolution in terms of genomics identification. Now the question is to see if there is any other biomarkers of interest for diagnostic, and also to see if this approach is suitable for non-human vertebrates, for the One Health approaches. So we are doing a lot of work in prospectively, but in retrospective, we are really lucky to have a huge biobank. So now we have a biobank of 6,000 viral strains available in our institution. So those historical HIV samples are poorly characterized. So we need to perform a molecular characterization of those neglected viral pathogens to maybe uncover the potential pathogen X. And a part of the work was done on a group of viruses called orthobunia viruses, where close to Rift Valley fever or Crimean Congo, for instance. So in this plot, we see that we have some viruses that can have some human or non-human primate as reservoirs, or rodents and bats and etc. So it means that thanks to this NJS and the retrospective analysis of pathogens in our biobank, we are able to have some key insight into pathogen ecology and potentially to discover some spillover events. And in one of the samples, we have been able to identify this virus called the Inquavuma virus. We have been able to identify, thanks to the structural biology, a specific protein that merged perfectly with Oropuche virus. It was previously mentioned in one of the previous slides. So this incognito is the African Oropouche virus is a question mark that needs to be answered, but it's a proof that our approach can go from the DNA or RNA to the protein structure to the risk prediction and maybe drug target identification. And we need to see now how we can ensure the synergy between structural biology and genomics to leverage and predict for the future pandemic. So we are talking about the centenary of IPD, and we have a huge experience on infectious diseases. And now a new chapter is now to be opened. So now we are poised to go to non-communicable diseases and genomic medicine. And of course, if we have a better information on the genomic predisposition, or we can propose tailored therapies for our local population, it will be a key point to tackle chronic diseases, chronic illnesses, cancers, cardiovascular illnesses, and diabetes, and etc. And these things is our new area, new way to go in the next maybe centenary. So as a takeaway, I would say genomics can transform public health. It's obvious by the rapid identification and monitoring of pathogens. We have seen that structural biology adds depth, because we have seen that we may have an African Oropouche maybe. We showed that through impactful case studies that genomic surveillance demonstrates is a huge tool in real world. The biomarkers approach can enhance diagnostic and in addition to genomics. And for the IPD's next century, we want to expand our activities into genomic medicine for communicable and non-communicable diseases to tackle new challenges. So, and all these things with my colleague here, it's a multidisciplinary approach with immunology, with mathematics, and we never talk about all AI approaches that need to be covered in order to have better information. This is one of my favorite slides because it shows that all things needs a team. Science is a question of teamwork. So it's not all. It was not possible to add all the people that are engaged now in this part of activities in IPD. But thanks to everybody that are linked more to this type of activity related to genomics in IPD. And thank you to all the collaborators outside the institution too. Thank you very much.
Thank you, Dr. Moussa Moïse. Thank you for this nice talk, which shows the importance of genomics in pathogen surveillance and pathogen discovery. We're going to move now on another presentation with Andy Diouf. Andy Diouf works a lot on mobile laboratories with diagnostic. Andy, you have the floor is yours. Thank you.
Right. Hello, good morning, everybody. So my presentation will be on French, but I try to translate from time to time. So we can get started. Donc, bonjour à tous. Mon nom est Andy Diouf, étudiant-chercheur au sein du pôle de virologie de l'Institut Pasteur de Dakar. Et je travaille dans les arboviroses et les virus à fièvre hémorragique dans l'équipe du docteur Omar Faye, qui malheureusement n'a pas pu être là ce matin. Donc, de quoi on va parler aujourd'hui? On va parler de comment renforcer la surveillance des arbovirus et des VHF, des virus à fièvre hémorragique, en utilisant des outils de diagnostic innovants. Donc, pourquoi nous devons nous intéresser à ça? C'est parce que d'abord, on sait que, évidemment, les maladies émergentes sont de plus en plus une menace de santé publique dans le monde, avec le réchauffement climatique qui fait que les vecteurs sont beaucoup plus distribués, ce qui fait que nous avons des maladies comme la dengue, chikungunya, la fièvre jaune, Zika qui se répandent de plus en plus et qui causent justement des symptômes fébriles et qui peuvent également évoluer pour certaines de ces maladies vers des symptômes hémorragiques. Donc, la distribution de ces maladies, présentement, on peut les retrouver quasiment partout dans le monde. Et on peut voir qu'en Afrique, on a la co-circulation de toutes ces, d'une bonne partie en tout cas, genre de ces pathogènes. So in Africa, we have co-circulation of many of these pathogens. Donc un peu plus en détail, ici on peut les avoir comme, on a également des virus à fièvre hémorragique comme l'Lassa qu'on retrouve pas mal en Afrique de l'Ouest. On a Crimée-Congo qu'on peut retrouver également dans d'autres zones et également genre les autres maladies comme Ebola, Marburg, la dengue ou encore la fièvre jaune. Cependant, il y a un problème qui se pose. Le problème qui se pose, c'est le manque d'outils de diagnostic appropriés au niveau des zones où ces épidémies se déroulent. Également, nous avons un très faible nombre de laboratoires de référence et c'est ce qu'on peut voir dans l'autre figure ici. On en a certains pour les arbovirus et les virus à fièvre hémorragique à Dakar, en Afrique de l'Ouest et en Afrique du Sud. Ce qui fait que lorsqu'on a par exemple une épidémie au niveau central en Afrique, les échantillons doivent faire des jours pour aller au niveau genre des laboratoires centrales, ce qui peut amener genre des problèmes de délai assez importants. Donc, qu'est-ce qu'il faut faire ici? Il faudrait donc ramener le diagnostic plus proche des zones où c'est nécessaire. We have to bring diagnostic closer to the people at the point of care, right? So, if we want to do that, we know that in molecular diagnostic, particulièrement dans le diagnostic moléculaire, la PCR est la méthode de référence. Mais comme on peut le voir sur cette image, ça demande des outils sophistiqués qui sont difficilement déployables et on sait également que dans ces zones qui sont reculées, l'accès peut être assez compliqué. Donc, à quoi doit ressembler un outil de diagnostic adapté pour le terrain? Ça doit être un outil qui est sensible, un outil qui fournit des résultats rapidement, un outil qui ne coûte pas cher, qui est facile d'usage et facile à déplacer, et également qui reste stable. Et donc là, le premier outil que je vais vous présenter, que nous travaillons en virologie, avec cet outil-là, sous l'équipe de Dr Omar Faye, il s'agit ici de la RPA. En quoi consiste la RPA? Vous avez tous entendu parler de la PCR, particulièrement pendant la COVID-19. À quoi correspond la PCR? C'est tout simplement un outil qui utilise différentes températures et un cocktail biochimique pour photocopier un peu le virus s'il est présent. La RPA fait la même chose. Cependant, il n'utilise pas de cycle de température, un cocktail biochimique un peu plus simple, ce qui fait que on a des appareils beaucoup plus faciles à utiliser, des appareils genre de petite taille, et surtout, on les a intégrés à des valises que je vais vous montrer dans la slide suivante, ce qui fait que c'est un outil qui est beaucoup plus déployable sur le terrain, qui a quand même la sensibilité d'un diagnostic moléculaire. Donc, voici à quoi ressemble l'outil lorsqu'il est déployé. Donc, nous pouvons voir ici qu'on peut utiliser genre soit deux valises ou bien on peut utiliser également genre une glove box. On a des réactifs qui sont lyophilisés, donc c'est-à-dire il n'y a pas de problème de transport par rapport à l'indisponibilité justement genre de certaines enseignes thermiques. Nous savons que lorsqu'on parle genre de zones reculées, souvent nous avons pas de courant, souvent nous n'avons pas les facilités pour utiliser ce genre de choses. Et donc voici à quoi j'en ressemble les résultats d'un test RPA. Et donc là, plus en détail, nous allons parler de cas réels d'utilisation lors d'épidémies. Donc, pour la dengue au Sénégal, je vais parler sous le contrôle d'un collègue ici, Idrissa Dieng. Donc, ils ont eu à participer justement à un déploiement en utilisant les outils que vous voyez genre sur l'image suivante. Et ces outils aujourd'hui nous permettent genre de traiter les échantillons, de faire la partie préanalytique, donc c'est-à-dire l'extraction, et après de faire la détection sur valise. Donc, voici à quoi ressemble le laboratoire au complet. Juste ces deux outils-là, et ils ont pu être déployés genre sur le terrain, et on peut gagner un temps considérable en utilisant cette technologie parce que le test, on peut obtenir les résultats en 10 à 15 minutes, ce qui est très différent de ce qui se fait au niveau genre des laboratoires centraux. Et donc ici, ces tests ont été faits en comparant justement la méthode RPA et également la méthode de référence qui est la RT-PCR. Et nous avons vu qu'il y a une bonne concordance entre ces deux résultats, ce qui montre que c'est un outil qui peut être utilisé aujourd'hui dans des situations réelles d'épidémie. L'autre utilisation de la RPA qui a été faite, c'était lors de l'épidémie d'Ebola en Guinée. Et donc, l'Institut Pasteur de Dakar fait partie des laboratoires qui ont été déployés sur le terrain. Et particulièrement, il y avait un problème qui subsistait, c'était le problème des enterrements, des procédures d'enterrement, parce que beaucoup de contaminations survenaient au niveau de ces processus-là. Donc, ce qu'il a été question ici, c'est comment tester ces gens-là avant de les enterrer afin qu'on puisse avoir les résultats rapidement et permettre aux familles d'enterrer dignement leurs membres. C'est dans ce cadre-là que cet outil RPA a nouvellement été déployé et nous pouvons voir sur ces images que tout peut rentrer dans une voiture et on peut amener ça directement au niveau du point of care, ce qui veut dire au niveau où le besoin se trouve. Et ici, ça, c'est les résultats qu'on a pu avoir sur cette étude-là. Et ce qui est intéressant de voir, c'est que les méthodes de référence qui sont utilisées dans le cadre des épidémies, c'est-à-dire la RT-PCR et la RPA, ont quasiment eu les mêmes résultats, ce qui indique une très bonne concordance. Which shows how this method can be easily used in epidemics because it has like similar sensitivity as the PCR method. Now, another tool that we use also in innovative diagnostic at IPD is the mobile lab. So, as you can see here, we have a lab that we can literally bring to the point of care. Donc ici, nous avons un laboratoire que nous pouvons littéralement amener au point of care. Il y a 4 principaux soucis que ce camion laboratoire mobile nous permet de résoudre. Donc le premier, évidemment, c'est l'accessibilité au niveau du point où on en a besoin. Le deuxième, c'est l'autonomie, vu qu'il peut fonctionner avec ses propres batteries. Et ensuite, il y a aussi le niveau de biosécurité en travaillant avec des agents pathogènes dangereux. Et aussi, il y a la connectivité. Donc ici aussi, nous allons voir des réels cas d'épidémie où ces camions ont pu être utilisés. Donc le premier, c'est un déploiement pour la dengue. Il a été constaté en 2017 une augmentation assez importante du nombre de cas fébriles. Et au laboratoire central, on a pu confirmer qu'il s'agissait d'une épidémie de dengue. Et ensuite, ce camion a pu être déployé sur place, à Louga. Et donc ici, nous voyons un peu certaines images de l'intérieur du camion. Et à l'intérieur, on se crée un workflow, donc un flow de travail. We just create a workflow inside the mobile laboratory. Et avec ce camion, nous pouvons donc faire les étapes de réception de l'échantillon. Nous pouvons faire les étapes d'inactivation avec le cabinet de biosécurité. Nous pouvons faire la détection moléculaire. Nous pouvons également faire le séquençage et le stockage aussi de ces échantillons parce qu'il y a des enceintes thermiques dans le camion. Et surtout, nous pouvons faire la communication des résultats en temps réel. Et c'est ce qui a été le cas d'ailleurs en 2017. Dès que les résultats avaient pu être obtenus, ils ont pu être téléchargés sur la plateforme Teranga afin que les décideurs en temps réel puissent voir ces résultats-là. Donc, au niveau de cette épidémie, on a plus de 960 cas suspects qui ont été testés avec 131 cas qui ont été confirmés. Et l'autre exemple qu'on peut utiliser, c'est l'exemple du déploiement avec la COVID. The other example that we can use is the deployment with COVID-19. Et pendant cette épidémie-là, au début de la pandémie, on va dire, le camion laboratoire mobile a pu être déplacé à Touba. Et puis, on a adapté ce workflow-là, ce qui nous a permis aujourd'hui de tester plus de 11 693 échantillons qui provenaient de différentes régions entre mars et août 2021. Et on a vu que 10,6% de ces cas-là étaient positifs au COVID-19. So we were able to diagnose 11,000 samples from 10 different regions in Senegal, and we found that 10% of those were positive with COVID-19. So what do we need to understand with this? Qu'est-ce que nous devons comprendre avec ça? C'est que le diagnostic précoce des maladies est vraiment primordial. Plutôt la représentante de l'OMS nous avait parlé du fait que la PCR a pu être rendue disponible partout très rapidement. Cependant, certaines zones ne sont pas en mesure justement d'utiliser ces outils sophistiqués comme la PCR. Donc, comment faire avec ces gens-là? Donc, les laboratoires spécialisés comme ceux-ci peuvent nous permettre de répondre à cela. Ensuite, nous avons les plateformes valises et camions également qui ont pu être évalués au Sénégal. Donc, nous avons pu avoir des résultats qui montrent à quel point ces plateformes-là sont utiles. L'autre message, ce serait peut-être le turnaround time. So, là, on parle de temps de traitement des échantillons qui est drastiquement réduit. On peut parler de 48 heures en en temps normal. Avec ces outils, nous pouvons passer de 48 heures à 2 heures. On peut pas également parler genre du fait que ces innovations-là pourront être appliquées, parce que là, on parle principalement de diagnostic moléculaire, mais ils pourront être également appliqués aux essais, au diagnostic sérologique. Et nous pourrons également introduire, en termes de perspective, nous songeons également à intégrer de plus en plus ces plateformes, des plateformes de génomique dans les laboratoires mobiles, afin de pouvoir faire de la surveillance, de la détection, mais également genre du séquençage sur le terrain. So, voilà un peu pour ma présentation sur les diagnostics mobiles de l'Institut Pasteur. Merci.
Merci, Monsieur Diouf, pour cette belle présentation qui montre l'importance du diagnostic en santé publique au chevet des malades, mais également l'utilité de ces laboratoires mobiles dans les zones reculées. We will move on our last talk from math to biology with Dr. Mayam Diarra.
Okay, so thank you, Henriette. Hello, everyone. I'm delighted to be here today to talk to you about how mathematics contributes to biology. So we can have the slides, please. Okay, so I'm a research scientist at the Epidemiology and Data Science Department, and I'm talking on behalf of Sheikh Lukubar, who is the head of the department. So okay, so I know that most of you are asking why we are using modeling here in MyPD in the area of biology. So just to give you a brief representation of what is mathematical modeling, is just we have, for example, the real world, which can be the disease, and then we need to know very well the disease, try to have the key component of the disease translate in the model words, and using the model words with the key component of the disease, we can translate to the model. So just an example here, for example, you have the picture of Mandela, and what we are trying to do here is we try to keep the key component of the picture and try to reproduce the reality. And this is, in this other part, this is what is modeling. We cannot take everything in the model, but we take the key component of the disease or the transmission of the disease, and we will translate into equations and try to predict or do scenarios. And here we can add more complexity of the modeling. Here we have the model. We can add, for example, the color of the hair, the skin, and so on, to be more close to the reality. This is just what modeling does. And then once we have the model more close to the reality, we can do forecasting to prevent for future events, or also we can build some scenarios to see what's happening. Here, for example, I want to just give an example of the COVID-19 model diagram we used at the COVID-19 International Modeling Consortium, which is based in Oxford University. Pasteur Institute is part of that. And then here, this is just the representation of the disease. Here you have, for example, from the susceptible people to the infected, and the infected people, you have different ways. The infected with no symptoms, with self-isolated, with mild symptom, infective with hospitalizations, and then you can have the recover, which can be again susceptible again. So this is just a brief example of how we can take the key component of the transmission dynamics in the disease and try to build a model on that. And once we know very well the transmission, the key component of the model, we can also add some component like, for example, vaccinations and so on, and we can build some scenarios on that. And here, this is the part where we can add, we have the mathematical parts. We take the diagram I showed before, and we will translate into equations, and based on that, we can build some scenarios or forecasting. Here, this is just an example of COVID-19 we have done during the pandemics. In dots, this is in black dots. This is the real cases of COVID-19 we have in the surveillance, and in lines you have the models with and without vaccinations. And once we have the model, which can fit well our context, we can do forecasting. And here, you can see that, for example, the model we built during COVID-19 can forecast, for example, if we can have a new waves coming, or what is the transmission, the intensity of the waves, or when it will happen. And here, depending on the questions the Ministry of Health were addressing, we were able to do forecasting. And unfortunately, we experienced the third wave, which was predicted by the model. And then we relaunch again the model depending on other factors they are asking. And depending on the questions you are addressing, we can add more complexity to the model and try to predict and see what's happening. This is just an example of this forecasting. And also, depending on your modeling questions, for example, how long should NPIs, this is the non-pharmaceutical interventions, would be maintained during vaccine rollout. We know that vaccinating people and keeping all control measures at the same time will be heavy for the people. So what will be the best, for example, scenarios? Should we keep vaccinations and again keep measures, control measures at the same time, or what will be the best time period to relax, for example, NPI? And using those models we already built, we can launch different scenarios with different time periods. And here, this is the key message here for the daily cases and also for the cumulative number of deaths. The model can say that the optimal period to relax NPI would be a few days after the last peak. Here it is in the pink curve, which correspond, for example, few days after a school closure and so on. So this is some kind of information and scenarios we can have through modeling. Also, another question we asked during the pandemics is, what are the best vaccination strategies? Here, at the beginning, when we have vaccines, usually we started with for vaccinating only for healthcare workers and people with comorbidities and people for more than 6 years old. So we try to see what would be the best vaccine strategies to prevent more, be able to prevent more, to save more lives. So here we launch different types. We see that in the blue curve, if we don't vaccine, this is the higher curve we have. And if you vaccine, for example, for the younger one, for the people over 6 years old, we vaccine also for all the population. The model can say that it is better to vaccine the whole population, so you can protect everyone and try to see how modeling can help also to the cumulative number of deaths. And here the key message is it is better to vaccinate the whole population, not just the elderly or those at high risk. These are all the type of analysis we are doing in the data science department. And here we are just trying to see the link between climate and health. And using this link, try to help to link this data. We can, for example, do forecasting or prevent if we will have another outbreaks coming depending on climates, on human health, on vectors, on animals, and so on. But also we can include the movements of animals, where they are coming from and so on, where are the hubs for animals and how we can also here, for example, produce this real-time risk map using data analysis and statistical methods to see where and when we can have the potential hotspots of the disease, and also where and when we can have epidemics to prevent and to be able to prevent for future outbreaks. So also, we have done this work on dengue fever, and here this is data from the surveillance for the forest network, and you see that the spatiotemporal distribution of the relative risk of occurrence of dengue is changing through times. From 2015 to 2023, you see that the occurrence, the relative list is moving from one region to another, and the intensity is changing. So these are some studies we are doing, and this can help for decision making, and they can address well when and where they can put all their efforts to control the disease. So this is last. And thank you, everyone, for your listening.
Okay. Thank you, Dr. Mariam. Thank you for your nice talk, which shows the role of mathematics in biology. Thank you to all of our panelists. We have some questions for you. To better understand the role of immunology, genomics, and evolution in the perspective on the fight of emerging disease. I have the first one. Sorry. What are the most important open scientific questions in your field? We're gonna go first. Dr. Ines or Musa Moise?
So one of the most important questions in my field is to better understand this complexity of the immune response, not only in the blood, because when we are study this immune response, generally we study this immune response in the blood, but indeed we have to study this immune response in the tissue, in how to have more tools, very, very specific tools to study this immune response directly in the tissue, to better know where the disease is taking places, what is the immune responses around these diseases in the tissue. And also the diseases faced to cancer, and autoimmunity is one of the things that we want to investigate, because we know that the next 100 years will be years of cancer and autoimmunity. So how to face that and to respond very quickly to this cancer on our population.
So, Dr. Ines, everyone else? Dr. Musa?
Oh, okay, thank you very much. So this is a really large question. So some few ones are coming to my mind. So the first one I will say will be about the evolution itself. So we are talking about tracking mutations, and we see the evolution of pathogens, etc. So one thing is to know what is the part of the stochastic invert in this one. So usually we say that it's really random events that we have, like a mutation that can pop up. But more and more we have different approaches. I don't want to make maybe a spoil on the genomic algebra that shows some few things, like we can anticipate in upcoming mutations. So to see if there's a new way to predict a specific mutation will be a real important evolution in terms of genomics, because we're now able to do really predict real
accurate prediction in terms of mutations occurrence. One other thing that is also many more technical, the way to be more confident about the way to generate unicellular metagenomic approaches. Now, what we do is I would say like metagenomic on tissues, for instance. We know that as resolutives that we want, so getting be more in depth in terms of metagenomic approach will be also a key point for pathogen discovery. And maybe the last one is also the imputability. So now we are able to do like shotgun sequencing. You can identify a lot of DNA or RNA in a single samples. What is the real causes of a specific disease in a specific cases? That's why the use of transcriptomic approaches, for instance, could be of interest, and how to be 100% sure that among 2 to 3 potential pathogens, this one and only this one that cause the disease, or maybe the effect of 2 or 3 of those pathogens. So it will be some few points that can be of interest for the future.
Thank you, Dr. Moussa, for this. Andy, you want to say something? Or Maya? To let her first. Okay.
Yes.
Maya.
Henriette, I think that for the purpose of the data science, actually, the question is, for example, related to climate. So we see that for climate change, we have lots of reemergencies of dengue, for example, of even malaria. So what are the key factors depending on climates can explain, for example, the outbreaks or the future events of such reemergence. So we need to link many types of data. For example, for the climate one, we need also data from the past events. We need also, for example, other type of data such as vectors and so on. Keep the One Health approach. Try to learn more about the past and then be able to predict in the future. We are in LMEX, low and middle income countries, so we need to anticipate events. We need to, use the economy we have. We need to optimize how the government can put money in this strategy or other strategies. So I think modeling can help addressing this kind of questions. We need the One Health approach for data science and try to predict and see where and when we can have, for example, future outbreaks. Thank you.
Thank you, Miriam. Andy?
Yes.
Something to
Okay. So as for me, I think that someone here already asked the question. She asked, how ready are we for the next pandemic? So for my field, it would be how are the molecular tools that we use for diagnostic ready for the next pandemic? Why am I asking this? It's because we've seen with the past pandemic like COVID-19 that just passed, that we had diagnostic tool very quick in some points, but we in Senegal, especially in the very beginning of the pandemic, seen that only few labs, it was Institut Pasteur, I don't remember exactly who and who, that had the capacity actually to diagnose accurately the virus. So the question is, when the next pandemic will come, will we have like the same central labs inside the city and urban areas, like being the only one able to test for these viruses, or will we have some more developed diagnostic tool that we will be able to bring everywhere? So basically, that's what I showed earlier. It's very important to develop some tools that will be easy to deploy and that will allow
everybody for where the epidemic will be to do accurately the diagnosis of those viruses.
Thank you, Andy. A last question we have. In your opinion, what new profession and new technologies are likely to revolutionize the study of genome and pathogens?
Okay. This one is a tricky one. I would say we need a lot of new things, but what is really critical now is not like technical limitation, because now science is growing up. You have a lot of things, AI, and a lot of devices that we recently have a new sequences that pop up. So I will not say that it's mainly technical, is on the technical aspect, but mainly on the, in terms of legal aspect, because now we are able to, bioediting is easier, is like with the emergence of CRISPR-Cas9, every lab can do it theoretically. Bioediting is possible. We have also the possibility to do a lot of application using genomics, but we need rules, and we need specific rules to better control our actions. So I would say maybe a genomics lawyer, something like that, would be of interest to be sure that we are totally in the right way to proceed with our different actions. Sometimes we can overpass our prerogative and etc. So I would say this type of works, not like really technical one, but more in the high level to ensure that we are in phase with all the regulations at a national and international level. I don't know if my colleague has some other point.
Musa, Dr. Ines, you want to say
Maybe to add that what we need, of course, is to have new tools to investigate deeper into the genomics, the immunology, the virology. But what we need most is how to coordinate, how to organize all the data generated, and how to use AI, mathematical modeling, and genomic algebra to go faster than the pathogens, and to discover and to predict the antigens, the epitopes that will need it to develop and to put in place the good vaccine to strengthen our immunity to fight against the diseases and to be more prepared for the next diseases that can be introduced in the population. Thank you.
So, Dr. Ines, Mariam, you want to say something, or Andy? It's fine. Okay, thank you a lot to our panelists for your brilliant presentation, which shows the transversality between immunology, genomics, and evolution in the fight of emerging diseases. Thank you.
Thank you very much. Let's please give him another round of applause to the panel and to all the speakers from this morning. We have unfortunately run out of time, so if there's any burning questions, please feel free to reach out to any of the speakers from this morning and this afternoon. We'll take a lunch break at the moment. It is 2:07 here in Dakar. We'll take a lunch break for an hour and 15. So back in this room at 4:15. Is that right? 3:15. People are awake in the room. Perfect. All right. Have a good lunch, everybody, and see you soon.